Hello. Uh, Hello, everyone. Welcome you back after the lunch session. So we will be starting post-lunch session, which is PG presentations, paper presentations. So I would like Dr. Amir to come and start the proceedings. Dr. Amir, is he here? I think Dr. Amir is not here. Let me take his charge for a while. So the first post-lunch session is PG paper presentation. For this session, I would like to call upon the chairpersons, Dr. Nawab Ahmad Khan, Consultant Surgeon, Director Health Services, Kashmir. Dr. Nawab, is he here? Dr. Akashdeep, he is not here, sorry. Dr. Saeed Kupdia, she is not also here. Dr. Who can say in the chair, anybody? Dr. Ravinder, he is already in another session. So Dr. Mudassir Shadar, I would like you to please come to the chair. Dr. Shakib Loon, please come to the chair and chair this session for us. Dr. Shaukat Ali, we missed him in the first session, so I would like Dr. Shaukat Ali, Assistant Professor JMC Handwara, to come and chair this session. Shaukat. So, over to the chairperson for conducting this session.
Welcome everyone to the post-line session. May we invite the first speaker, who is Mohibu Farooq Jan, PG Surgery Skims. He will be speaking on sutures versus tacks, mesh fixation in IPOM.
Very good afternoon to the dear chairpersons, faculty, and all my colleagues here. I am Dr. Mohibul Farooq Jan. I am a second year surgical resident from Shahri Kashmir Institute of Medical Sciences. And today I'll be presenting a paper on suture versus tacks, mesh fixation technique in intraperitoneal onlay of mesh technique. Now, ventral wall hernias, they are affecting 0.5 to 1% of the population, and around 10% of the ventral hernias undergo incarceration and need otherwise an emergency laparotomy. A laparoscopic ventral wall hernia was introduced in the early 1990s by Carl Leblanc. And laparoscopic hernia may involve a primary closure technique with or without applying mesh to the suture. And the key methods for mesh fixation include sutures and tacks. Now, why a laparoscopic approach? It is known that it has a less wound morbidity, a shorter hospital stay, there's a lower recurrence rate, and an early return to the normal activity. New techniques are being developed to repair the ventral and incisional hernias by laparoscopy, and the mesh in an IPOM is placed in an intraperitoneal position and fixed to the surrounding intact peritoneal wall. Adequate fixation is obligatory to stabilize the position of the mesh while tissue ingrowth occurs. Proper fixation must avoid loosening of the mesh and must prevent contact of the adhesive non-protective side of the mesh with the viscera. And the most frequently used methods for fixation are tacks, which can be with or without transfascial abdominal sutures or with sutures alone. And it is widely accepted that the method of mesh fixation plays a major role in the development of post-operative pain. Mechanical mesh irritation with helical tacks may cause irritation to the peritoneum and muscle injury, and a transfascial suture may lead to tissue ischemia and entrapment leading to chronic pain. In our study, we had a randomized single center prospective study which lasted over 2 years. We undertook patients with ventral wall hernias in the age group of 15 to 80 years of age, patients who had an associated comorbidity with a chronic cough and an acute abdominal infection, or patients with an acute presentation of an abdominal wall hernia were excluded. And the patients were randomized into 3 groups: a group AS, who were subjected to an absorbable suture fixation, a group NS, who was subjected to a non-absorbable suture fixation, and we had a group double crowning, wherein we did a double crowning with absorbable spiral tacks. And in the surgical technique, the mesh was secured with sutures placed at 2 to 3 centimeter intervals. And in the double crowning, mesh was secured with spiral tacks plus sutures at the 4 corners. The objective of the study was to compare different mesh fixation techniques for laparoscopic abdominal hernia repairs, as well as to evaluate pain levels and recurrence of hernia post-surgery. In the follow-up, we asked the patients to visit the OPD at 3 weeks, 6 weeks, 3 months, 6 months, and 2 years intervals. And the primary outcomes were to look for the post-operative pain and to look for the hernia recurrence. In the demographics, we had a total of around 45 patients with a female to male ratio of 4:3. Age distribution was around 20 to 70, with maximum patients in the age group of 36 to 45 years of age. And in the study, 77.8% were having an incisional hernia, while 22.2% patients were having a primary hernia. And these pie charts are showing how the randomization took place in the 2 groups. And in our study, the severity of the pain was compared between the 3 groups in the pre-operative and in the post-operative period at 3 weeks and 3 months using a VAS scale, wherein the patients were asked to grade their pain from 1 to 10. And the difference in the pain scores between the groups was found to be statistically insignificant. Another thing we looked at was the operative time, and what we found that double crowning spiral tacking, it reduced the operative time, and it was statistically significant, with the time being reduced around 2.2 hours, while as for suture fixation, it lasted for around 4.5 hours. Hospital stay, we found that patients who were subjected to the double crowning, they had a significantly shorter stay, while as patients who were subjected to absorbable or non-absorbable suture groups, they had a significantly shorter stay. But in between the suture groups, the difference was statistically insignificant. Coming to the discussion, a laparoscopic repair of ventral and incisional hernias has significantly advanced in biomaterials since 1993. There is still an ongoing debate about the optimal method for mesh fixation against the abdominal wall in a laparoscopic ventral hernia repair. In the study, we used standard composite mesh, which was fixed with absorbable sutures or non-absorbable sutures, or with 2 circles of tacks. And sutures were made to pass through all layers of fascia and muscle. Tackers, they secured the mesh to the innermost millimeters of the abdominal wall. And like I previously emphasized, patients were in the age group of 29 to 70, and the mean age of all the patients in the groups was around 43 to 45 years of age. We found a similar study in the literature by Vasanar et al., who found a mean patient age of 51, 54, and 52 years in the 3 groups. He also observed a female predominance like we observed in our study. Other comparative studies like by Nguyen and Bangash et al., they also found a female to male ratio of around 2:1. And like I said, the majority of the hernias were incisional. Anecdotal evidence suggests more pain after repair with sutures than tacks, possibly because of the local muscle ischemia. However, in our study, there was no statistical difference in pain scores at 3 weeks and 3 months among the 3 groups. Nguyen et al., Vasanar et al. Also found no significant difference in pain scores between sutures and tack groups. Carbajo et al. Reported a higher post-operative pain with 2 circles of tacks compared to sutures, and Bagiku et al. Observed severe pain in patients with tacks compared to sutures. The study showed that using tacks for mesh fixation was quicker than using sutures, and Maisums et al. Had a similar finding, wherein he also concluded that tacks reduce the operative time compared to sutures and tacks. In our study, we had no hernia recurrence over a 2-year period. 4 patients developed seromas. 2 of them were from the non-absorbable group, 1 each from the absorbable and the double crowning group. There was no reported mesh infection, there was no wound infection, there was no mesh migration. Mean hospital stay was around 3 days for double crowning, and it was around 6 days for the suture groups. And we found comparative studies by Bangash and Vasanar et al., who did report a recurrence of around 6% in both tacker and suture groups. and there were no major complications like I previously said. So my conclusion of my paper was that there was no significant pain reduction between the three techniques, and double crowning with tax shows advantage in a shorter operative time and a shorter hospital stay. Thank you.
Well done, Dr. Mohib, for a nice presentation. The
Okay, what was the diameter of hernia in these cases?
So I'm not here.
What was the diameter of hernia?
So,
And was there any association between the diameter of hernia and the recurrence in this patient?
so most of the hernias, we had incisional hernias, and most of the patients were female patients. They usually had a classical cesarean section. They had a history of, so diameter was under 5 centimeters in majority of the cases.
And was there an association between the...
So we didn't evaluate for any association, but what we there was no, we didn't look for
Did
any.
you alert it for this hernia recurrence or not?
Yes, so we followed them for 2 years, but we had no hernia recurrence in our study.
I have a query. You said most of your hernias were post-LSCS.
Yes,
Do you do
no,
IPOM?
no, sir, classical, not LS, classical cesarean sections.
Classical cesarean
Yeah,
section. Okay, what was the diameter like?
So it was under 5 centimeters, the hernia in majority of the cases.
Fine.
I just wanted to know whether you were closing the defects or not.
Yes, sir, we were. No, sir, we were not closing. We were doing an IPOM, not an IPOM. Plus.
Not an IPOM plus.
Without. Thank
Okay, thank you.
Thank you.
a round of applause for Dr. Mohib. I call upon stage Dr. Priya Bhagat. She is a postgraduate scholar from SKIMS. She will present a paper on intraoperative inking for assessment of margins of lumpectomy.
Can I get help with this? A very good afternoon, respected chairperson, delegate. This is Dr. Priya Bhagat, PG scholar from SKIMS SORA, stands before you to delve into the role of intraoperative inking for specimens of lumpectomy. Once again, a very good afternoon, respected chairperson, delegate. This is Dr. Priya Bhagat from SKIMS SORA, stands before you to delve into the role of intraoperative inking for assessment for margins of lumpectomy specimens of carcinoma breast, a tertiary care experience. As we all know that breast carcinoma is the most common malignancy seen in women, but many advances As we all know that breast carcinoma is the most common malignancy seen in women, but many advances in breast health awareness with improved screening, early detection, with more effective systemic therapy have resulted in considerably decline in carcinoma mortality rates accounting for 2% per year. This was a prospective observational study which took place in the Department of General and Minimal Invasive Surgery along with the other two departments of Surgical Oncology and Pathology SKIMS over a time period of 18 months with 44 patients as the sample size. We included all the patients who needed surgery for breast carcinoma and they were consensual for longitudinal follow-up. We excluded those patients who didn't consent to re-excision after positive margins, patients who received pre-operative chemo and or radiotherapy, patients with metastasis at presentation, and patients with recurrent breast carcinoma. We investigated all these patients with using the triple assessment protocol involving the clinical assessment, the radiographic assessment, which included mammography and ultrasonography, pathological assessment, which included FNAC and core-needle biopsy. All these patients in our study, they underwent breast conservation surgery, that is BCS. On the basis of the we basically divided all our patients broadly into two groups based on the suture marking of the specimens or the intraoperative inking of the specimens. In suture marking, surgeon placed 2 or more sutures to orient the specimen, and then all the specimens were sent to pathology with comments correlating sutures to specified margins, and then afterwards they were inked by the pathologist. On the other hand, intraoperative inking. In intraoperative inking, surgeon painted the surface of each margin of the specimen as anterior, inferior, lateral, medial, posterior and superior with different colors. And all these inked specimens were then sent to pathology with a card-defined color-coded margin. Radiography in case of suture marking of specimen, if needed, was done after the suture placement but prior to the inking by the pathologist. And in case of intraoperating inking group, inking was done on a sterile back table in the operating room immediately after removal from the patient by the operating surgeon and prior to any additional imaging or radiography. You can see some images of the suture marking of the lumpectomy specimen showing short as superior, which is the conventional method, and the long lateral. In the second picture, you can see the specimen which is inked with different colors correlating to the different markings. Our results, they were based on the re-excision rate and the residual disease which occurred after the excision. We saw that in suture marking patients, re-excision was done in 9.1% of the patient, and in intra-op inking group, it was done only in 13.6% of the patients. Whereas residual disease on excision, it was found in almost 50% of the patients of suture marking group, and it was found in 66.6% of the patients in the intraoperative inking group. So basically, we concluded after this study that there was no statistically significant difference in re-excision rates between the two groups, and similarly, there was also no statistically significant difference in the residual disease after excision between the two groups. But we concluded that the margin positivity rate was lower in our study, due to which it was difficult for us to prove the superiority of one method over the other. But however, we can use inking method as a suitable and a simple alternative to conventional suture method for margin demarcation. Thank you.
Thank you for the presentation. Any questions from the audience, please? Yes.
Nice presentation, Dr. Priya. Quick 3 questions. One, you said in triple assessment you're doing FNAC versus core biopsy in some.
No, ma'am.
So what is the role of FNAC in breast cancers in current era?
Ma'am, actually, after this study, we also saw that most of our patients, they had nodal positivity, and most of the patients, they also presented after the results came from the pathologist. They had DC.
My question is very precise. The role of FNAC in current era for breast cancers?
Ma'am, it helps.
Only axilla. Please remember, you're not getting any further information on FNAC, and you cannot in current era base your treatment of the breast cancers wherein you're giving 1.5 centimeter tumors that are triple negative and HER2 positive, neoadjuvant chemotherapy for survival benefits. So no question of FNAC on the breast, and it is only for the axilla to see whether it is there
Actually,
or not.
ma'am, in our patients, we had mean age of only 40 and 45 years, and the patient who presented with us, they were the first encounter patients who had simple breast lump, so we had to assess the patients for...
By risk 3 onwards, no role of FNAC. All the more important if your patient is 40 and 45, because we are facing a situation wherein our patients are having a decade earlier cancers in our patients. Young age breast cancer is very common in our population, and all of them are majority of the times triple negative breast cancers, right? And number two, you said margin positivity in these. What is your institutional protocol? What margins do you take as negative for the invasive and what do you take negative for the DCIS?
Basically, in our study, we took the conventional 1 mm margin.
Thank
for
you,
the
Dr. Priya, for a wonderful presentation.
Yeah,
Now,
good question.
I call upon Dr. Mahmood Yaqub. He is an F&B resident in GMC Srinagar.
Actually, because of the shortage of time, we are allowing only one question for the audience. So please be brief and only one question.
Respected Chairperson, esteemed audience, Assalamu alaikum. I am presenting laparoscopic Heller's cardiomyotomy for achalasia cardia. As we all know, achalasia cardia is a rare motility disorder of the esophagus characterized by impaired relaxation of the lower esophageal sphincter and absent or spastic contractions in the esophageal body. Pathophysiological mechanism is loss of inhibitory myendric nerve function. Clinical presentation cardinal symptoms consist of dysphagia, regurgitation, chest pain, and weight loss. And there is a score, ECOT score, which we use mostly in the post-op period for response of the therapy. It involves weight loss, dysphagia, retrosternal pain, and regurgitation. We diagnose it by upper GI endoscopy, which shows dilated esophagus with retained food and saliva and puckering of GE junction. Also barium swallow, as we all know, it shows bird beaking typical. The conventional manometry shows features failure to relax, LES, ineffective contractions of body of esophagus, and less pressure greater than 26 mmHg. The diagnosis of choice is high resolution manometry. We divide it according to the Chicago classification, type 1, classic achalasia, type 2, this in which there is pan-esophageal pressurization, and the type 3 vigorous or spastic achalasia. Treatment accordingly differs to the type of the achalasia. So, Uzar, video screen, minimize करो, minimize video चला रहा है. She was a young female. She had undergone 2 balloon dilatations. So, there are different treatment options, starting from oral medications, nitrates, calcium channel blockers, botulinum toxin, and definitive therapies involving pneumatic dilatation, surgical myectomy, and coil. So our patient, she was 28-year-old female, complaints of regurgitation, chest pain, and mild dysphagia. Barium swallow showed typical features of achalasia cardia, and HRM was suggestive of type 1 achalasia cardia. She had patient had already undergone 2 balloon dilatations. So we planned laparoscopic Heller's cardiomyotomy with tope fundoplication. So this is the patient position, spine with steep reverse Sternberg position and leg split. Surgeon comes between the legs and camera surgeon on right side and monitor at the head end near left shoulder. So this is the video. We start our dissection from pars flexida, transparent membrane. Then we open the phrenoesophageal membrane and visualize the right crus of diaphragm, the right crus, and then we start mobilizing esophagus from the right crus. Here we have to take care of posterior vagi, we have to prevent injury to the posterior vagi. Then on the left side we open phrenoesophageal membrane and find left crus. We do the circumferential dissection around esophagus. because in this we are planning a posterior fundoplication. So mobilizing intra-abdominal length of esophagus, circumferential, we use blunt dissection. We have also used one retracting port which retracts the stem that helps in dissection. So after completing this dissection, we near G, just proximal to G junction, we start splitting the muscle fibers, both outer circular and inner longitudinal muscle fibers. We can use energy source or blunt dissection by using Maryland 2 Maryland forceps. We do it approximately 6 centimeter on the esophagus and 1 to 2 centimeter on the stomach part, which is important. The stomach side is a little bit thicker. There is oblique muscle layer also. So we ensure that mucosa should pout out. So we are splitting the muscle fibers, the myotomy, so that only mucosa is visible. Then we do intraop GI endoscopy ourselves to ensure that job is done. Only mucosa, this is beautifully shows only mucosa is visible, and also we can do air leak test to rule out any mucosal injury. Then we mobilize the fundus, short gastric vessels we are releasing. Because we are doing a posterior fundoplication to prevent the reflux. So 270-degree tope fundoplication, we have freely taken this fundus. We prefer tope or door fundoplication. So now we are taking interrupted sutures with the myotomy on one side and then on the other side, so that there is no herniation of the wrap. We are using non-absorbable suture, interrupted sutures, first on the right side. Also, we take suture with the crust so as to prevent the migration of the wrap. Now on the left side, so this is 270-degree. This is advantage over POEM that reflux is prevented because we add fundoplication. Again, interrupted sutures on the left side with the edge of the myotomy on the left side, so that this myotomy remains open. For liver retraction, we use Nathanson retractor, which is a very beautiful retracting instrument. Just So this completes our procedure. Follow-up, we start our SIPs just 6 hours after surgery, and our patients are usually discharged on post-op day 2. We start liquid diet for 1 week and followed with soft diet, a regular diet after 1 month. So we conclude by saying that lap myotomy with forcing fundoplication is considered the standard of care for patients with achalasia. However, proper evaluation of the patient for diagnosing the disease and patient selection remains prerequisite, because lower response rate has been seen with type 3 or spastic achalasia. Thank you.
Thank you. Thank you, Dr. Yakub, for a wonderful presentation. Any questions from the query? Any questions? Thank you. Thank you very much. Our next presenter is Dr. Mohammed Jameel, postgraduate student, GMC Srinagar, who is going to present laparoscopy hepatojejunostomy in benign biliary disease. Dr. Mohammed Jameel.
So I would like to make an announcement that the PG poster presentation, which is a competitive event, and the first 3 positions will be awarded, will be started shortly at 3. So in the corridor, we have displayed all the posters. So those PGs who are presenting, kindly be ready with your poster. So for that, moderators will be Professor Ijaz Ahmad Malik, HOD Schemes, Dr. Shamsul Bari, Associate Professor, Schemes Medical College, Dr. Natasha Thakur, she is not here probably, Dr. Junaid Mohammad Lankar, and Dr. Abid Wani, APGMC Baramulla. So Dr. Rahima, kindly provide with the paper and the pen to the moderators, and it will start at 3 sharp.
A warm good afternoon to all the faculty members, chairpersons, delegates and organizers. Myself is Dr. Jamil, postgraduate scholar from the Department of General Surgery and Minimal Access Surgery, GMC Srinagar. Now I am here to present the experience of laparoscopic hepatogenostomy in the management of benign biliary disease such as OCH, benign biliary strictures and colorectal cyst type 1. Introduction. The hepatogenostomy is the surgical creations of communication between common bile duct and jejunum. In 1921, Reeds used the term colorectal and hepatogenostomy term was first used by Sander in 1949. It was late 70, the first evaluation of feasibility and safety of Roe and by hepatogenostomy in the management of benign biliary disease was published by B. Smith et al. In a retrospective analysis of 123 patients. After that, in 1998, the Brilliant and et al. First experienced the laparoscopic hepatogenostomy in the management of benign biliary hepatitis disease. What is ideal hepatogenostomy? It should be tension-free, it should be well vascularized, it should have adequate diameter, it should have mucosa to mucosa approximation. And from the recent studies all around the globe, it was found that laparoscopic approach for the laparoscopic hepatogenostomy approach for the benign biliary disease yields better results when compared with the open results. As mentioned in one of the prominent journal of world sages that laparoscopic approach is better than open, but at the same time it's technically more demanding.
I request the audience to please maintain the sanctity of the hall while the speakers are speaking. Please keep quiet.
Now the GMC Srinagar experience, it's a data of past 3 years from the June 21 to June 24. It include 38 patients with benign biliary disease and most of the patients have OCH because in Kashmir the ascaris is more common, so OCH patients are more in this study, and 4 colorectal cyst and 3 benign biliary stricture. And the GMC Srinagar experience, the main operating time was 180 minutes and in initial cases the time was more, about 3 to 4 hours, 240 minutes. Mean blood loss was 180 ml and average post-operative hospital stay was 5 days. And the follow-up at 2 weeks, 6 weeks and 6 months and 1 year. And these are the references with the Bhubaneswar AIMS. In GMC Srinagar's, the operative time and the mean blood loss was less as compared to AIMS. Now the GMC Srinagar experience, we removed rail tube and folies on post-op day 1. We start oral at post-op day 1 and drain remove on to post-op day 3 or 4 and discharge on post-op day 5 and 6. And the complications, 7 patients developed post-operative bile leak and 3 patients developed basal atelectasis and pneumonia and no biliary stricture at 1 year follow-up. Know the technique. First, we reset the pathology, for example, colorectal cyst or benign biliary strictures. After that, we have create Roe and Y limb. After that, we create hepatogenostomy and genogenostomy. This is the surgical video and these are the port placement. On diagnostic laparoscopy, we found there are a lot of adhesion present between the anterior parietal wall and the liver and GB was distended that clearly indicates perihepatitis. After that, adhesion lysis was done and after that, calloid After that, Callott's dissection was done. We dissect at the cystic plate. We clipped at the cystic duct at the junctions. After that, we clip the cystic vessels and ligate the cystic vessels. After that, we isolate the common bile duct. There was portal vein present. With the help of hydrodissection, we isolate the common bile duct. And by using vascular sling, we retract the common bile duct that helps for the dissections. After that, we dissect the distal end of the CBD and we suture the distal end with the use of barred suture in a continuous manner. And after that, we flush the proximal common hepatic duct to remove all the stones. After that, with the help of flexible cystoscopy, we visualize the common hepatic duct. After that, we take from the 30 centimeter from the digit flexure, we take jejunum for the creations of row and Y limb. We make a window in the mesentery, and with the help of reloaded 60 mm blue cartridge, we dissect the jejunum. After that, we create retrocolic tunnel, and we took the row and Y limb through the retrocolic tunnel in the supracolic compartment for the hepatogenostomy. And we make an enterotomy in the jejunum for the anastomosis. First, we anastomosis in the posterior layer of common bile duct and the jejunum in a continuous fashion. After that, interior anastomosis was done, and we took a hinge suture so it should be tension free. After that, we close the retrocolic tunnels so it prevents in future internal hernias. After that, jejunogenostomy was done, enterotomy was done on both the limb of jejunum, and with the help of 60 mm reload cartridge, we done anastomosis, jejunogenostomosis, and enterostomy was closed by barred suture in a continuous manner. After that, we dissect the GB from the GB fossa at the end because this helps in reduction of the liver. And 28 French drain was placed in Morrison space. And this is the operative faculty of the GMC Srinagar. And conclusion, laparoscopy surgery for benign biliary disease is safe and with acceptable result, but surgeon should have proficiency in laparoscopy surgery. Thank you.
It's open for any questions. Well, I think the audience is spellbound by the technique and the surgery operated. That's very nice. You don't see very often these.
Sir, because liver retractions. But sir, these additions are very weak.
Is the operating surgeon in the hall?
Yes, sir. Dr. Iqbal, sir.
What do you do with the proximal duct stones?
That's absolutely right, sir.
What you will do if there are proximal stones in right and hepatic duct?
Yes, sir.
If there are proximal stones, what you will do? What is the option with you?
Sir, we use flexible cystoscope to visualize and diagnose any stone in the common bile duct proximal. After that, we flush if they are stone are small, but if stone are large, we use laser lithotripsy. We break the stones in small pieces, and with the help of Bugatti and flushing, we remove all the stones, and we visualize the common hepatic duct, right and left hepatic duct completely with the use of cystoscope. And this is a urological instrument, but it really
What
helps
are
in
the
CBD.
selection criteria for the procedure?
Yes, sir.
Selection criteria for this procedure.
Sir, we patient with MRI intrahepatic duct stone without any parenchymal involvement, and we also done CT scan of these patients. And the choledochal cyst of type 1 and benign biliary strictures of E1 and E2.
Thank you, Dr. Jamil. Thank you.
Thank you, sir.
With this, we invite the last speaker of this session. Name is Dr. Anil Yalavarthi. He is a PG here in SDH Kupwara and will be speaking on incidental neuroendocrine tumor of the appendix in case of adenoCA ascending colon.
Good afternoon, everyone. Today I am going to present a case. First, I would like to thank my guide Dr. Gulzar Ahmad Bhatt and my co-guide Dr. Bilkis Ahmad Ghani and my HOD Dr. S. Ahmad Dar. Today I am going to present one case that we operated in our SDHK Kupwara. This is the case of incidental detection of appendiceal neuroendocrine tumor in a right hemicolectomy specimen. It's a specimen for colonic adenocarcinoma. Coming to introduction, neuroendocrine tumors of appendix are relatively rare and often discovered incidentally during appendectomies or other surgeries for other conditions. Appendiceal carcinoma is a rare neoplasm found in 0.3 to 0.9 appendiceal specimens. The tumor typically present a benign course, but their detection is crucial for appropriate staging and management. This case report is mainly emphasizes the importance of meticulous pathological examination in colorectal surgeries and clinical features, diagnostic criteria and management strategies for incidental appendiceal neuroendocrine tumors. Coming to the case, we have a case of 65 years old female patient with a 3 months history of pain abdomen and dyspepsia and constipation and bleeding PR. And physical examination is unremarkable. She is a mild tenderness in the epigastric region and there is no lump palpable also. And our investigation is hemoglobin is 8 grams, is anemic, and CA levels are on higher side 7.39. And we advise CC abdomen. CC abdomen showing enhanced thickening involving the cecum, ileocecal junction, and local lesional lymph nodes involvement. And we advise colonoscopy. Colonoscopy shows a friable polypedal growth at the proximal part of the ascending colon, causing luminal narrowing, and the scopies could not negotiate the growth. And the biopsy shows the moderate differentiated adenocarcinoma. And then we posted the case for right hemicolectomy, and we did stapled ileopolic anastomosis, and in operative findings were growth at cecum and ascending colon, and maximum dimension of the growth is 4 centimeters, extending up to the subserosa. Post-operative period is uneventful, and we put the patient on regular follow-up. And histological examination showed moderately differentiated adenocarcinoma. All margins of the tumor are free of tumor. Total lymph nodes yielded are 34. Out of 4 got positive for tumor. And coming to appendix examination, appendix involved, distal part of the appendix involved in a neuroendocrine tumor, and the size of the tumor is 0.1 centimeters. It is well differentiated neuroendocrine tumor with no lymphovascular and perineural invasion. Coming to discussion, incidental appendiceal neuroendocrine tumors are relatively rare, discovered in approximately 0.3 to 0.9% of appendectomy specimens. These tumors are often asymptomatic and typically present in benign course. The detection of these tumors during surgeries for other conditions, such as in this case of colonic adenocarcinoma, underscores the importance of thorough pathological examination of receptor specimens. These are very rare. There were very few cases reported in the literature of incidental detection of appendiceal neoplasm, and incidentally discovered in the case of resection done for other colorectal adenomas. The management and clinical implication of appendiceal neuroendocrine tumors based on the size of the tumor, location of the tumor, and histological features of the tumor. If the tumor is less than 1 centimeter, generally it is considered low risk, and we don't go for active management. When the tumor is 1 to 2 centimeters, additional imaging are required, and follow-up are recommended to monitor any signs of progression and metastasis. And if the tumor is more than 2 centimeters, those with high risk features usually necessitate the right hemicolectomy to ensure complete removal and to address potential metastatic spread. Coming to our patient treatment, the patient treatment plan include adjuvant chemotherapy, and the presence of NET did not alter the chemotherapy regimen because it is a small size and low grade nature. And discovery of these incidental tumors highlight the need for diligent follow-up, as patients with synchronous tumors may have increased risk of recurrence or development of new malignancies. Regular follow-up, including periodic imaging and CA level assessment, is essential for early detection of any recurrence or metastasis. This comprehensive approach ensures that incidental findings are not overlooked and that patients receive optimal care based on entity of their pathological findings. Coming to conclusion, this case underscores the importance of thorough pathological examination of resected specimens in colorectal surgeries, as incidental findings can significantly impact the patient management. Although incidental appendiceal neuroendocrine tumors are typically indolent and often do not require extensive surgical intervention, their detection is crucial for accurate staging and appropriate follow-up. Clinicians should be aware of the potentials of synchronous tumors and manage each case based on the individual risk factors and tumor characteristics. Thank you.
So any questions from the audience? Yeah.
I think we must commend Dr. Gulzar doing such a case in such a remote corner where he has no help. It takes a lot of courage, and I really appreciate what he's doing here. Congratulations.
Thank you, sir, for your encouraging words. Means a lot for me. Thank you. So we come to the conclusion of this session. So I would like Dr. G.M. Sheikh, sir, who is here. I welcome you, sir, and I would like you to come to the stage to felicitate our chairpersons. Please, sir. Dr. Shakib Nabi Loan. Sir.
I have to say something. Look, we're here, the speakers, they have to work a lot. It's not easy to make a presentation. They come here, they expect to be heard. And it's really unfortunate that there is so much noise here. Let's stop talking, let's listen to them. If you don't want to listen, then go out and talk.
So, GM Sheikh sir will present moment to the chairperson, Dr. Shakib Nabi Loan, Dr. Mudassir Nazar Shadar, and Dr. Shaukat Ali, ABGMC Handwara. And then, quickly, where are you waiting? I've already announced, sir, na? You be quick. So I will. Now the presenters, Dr. Mohib Farooq Jan, Dr. Priya Bhagat. Come quickly. Dr. Priya. Dr. Priya is not here. Dr. Yaqub, Mohammad Yaqub. Dr. Mohammad Jamil. Dr. Anil. Dr. Anil is also not here. So we have another announcement that we are conducting a PG quiz. It's again an award winning, so we'll be giving some token money or something, maybe a moment or to the winners. So those PGs who are interested in participating in this quiz, kindly register with Dr. Arshid sir and Dr. Abhishek. They are conducting this quiz at 4:30 to 5 p.m. So you get registered and then you will be taken for the quiz. So we are starting with another session, which is I think a good session, a panel discussion. The most that is the heart of I think of any conference. So for this discussion, I would like to call upon the dais, the chairpersons, Professor Dr. Iqbal Salim Mir. Sorry, sir, I call you actually Salim Iqbal, so that's why I am mumbling always. Sorry for that. His chairperson Jakasi and professor at head GMC Srinagar. Dr. Rais Ahmad Dar, HOD Surgery, SDHK Kupwara. Dr. Wasif Bashir is the radiologist at SDH Kupwara, the only radiologist in Kupwara in the government sector, I think so. Dr. Mushtaq Ahmad Sofi, AP Radiation Oncology Schemes. Is he here? I will adjust. 2 chairs, please. I think he is not here. Dr. Shabnam Bashir, consultant oncosurgeon, Ujala Cygnus. I think if we can adjust Dr. Javed Rasool Shah, is a pathologist in district, is the one of the renowned pathologists in district of Kupwara. Sir, please. Sorry, we have a small stage, so we have to adjust it. So for this session, the moderator is Dr. Shah Naveed, consultant oncosurgeon, Paras Hospital, Srinagar. So sorry, this is to be announced by the chairperson. So over to you, sir.
Assalamu alaikum. Good afternoon to all of you. I welcome the panelists on stage. So let us begin. There are just a couple of cases of regarding colorectal carcinoma. I would like to start. This is a 62-year-old male gentleman presented with the complaints of persistent rectal bleeding since one month, on and off. And there was changes in bowel habits for 2 months. On general physical examination, except pallor, nothing significant. Abdominal examination, nothing significant. On rectal examination, a mass was felt approximately 2 centimeters from the anal verge. I would like to start with my surgery colleagues. Dr. Rais, what next?
So after
Internally,
it is still considered locoregional nodes.
right.
Inguinal, extrailiac are considered as metastatic nodes.
Except in anal, I guess.
Okay, one. Now, how would you? Yes.
So, when it comes to regional nodes, it's again a divide between East and West, and Japan is an altogether different entity. They call it a regional disease and clear everything else, but we in this part are following the West, and we call it, metastatic disease. But again, I think it's a mix of things. It's not a categoric thing. It's not, you have to actually see whether it is, even if they are involved, they're oligometastatic. So that still does not really change the actual treatment part if they have responded well after your CTRT.
Okay.
You might just leave them
Just
there.
a quick question, a shortcut there. Say, for example, no lateral nodes are positive, and you have planned patient for some neoadjuvant treatment. Now the patient comes to table for reassessment for surgery. Would you take the lateral nodes?
So the lateral nodes that have completely responded well, if you take that patient for wait and watch, you apply the same to that. But if you're operating and you're well versed with the lateral node dissection, you might as well clear those as well.
That's okay. So my radiology colleague, once we are not done yet, because all the management in this depends upon your report. What about CRM?
CRM involvement normally would be a stage 3 disease.
No, I want a clear-cut answer. One is, you'll make me well aware about CRM. What is your definition about CRM? Once you report a patient of CA rectum, especially lower rectum, mid-lower rectum, how many millimeters do you take as CRM threatened, clear, or involved?
I think CRM is a misnomer when it comes to a radiological point of view. For us, it is MRF, mesorectal fascia.
Good.
So we normally report based on that finding,
Yes.
if that is involved or not. So if there is less than 1 mm distance between them, it's definitely involved.
And threatened?
Threatened would be more than 1 mm. If there
And
is
freeze more than 2
right,
mm?
yes, right.
Okay, good. So the CT in this patient was done, it was non-metastatic, and MRI, the main, it was T3, mesorectal fat invasion was involved, suspicious lymph nodes in perirectal area. What next? Tumor markers? Iqbal sir.
First of all, I'd like to add here that we are forgetting this one of the easiest methods of radiology, that is endo-ultrasound. Why don't we start it? Why don't we do it? It's
So
a very
what-
good.
Would you like to do endo-ultrasound with all the patients?
Of course, every patient who has a growth there, yes, I would love to do it before we take biopsy. The moment you take biopsy, it will all be gone because inflammation will set in. So please put it in your protocol if you have available.
You have a parietal examination, a hypothetical case, a parietal examination, a tumor at 1.5 to 2 centimeters from anal verge, fixed, posteriorly placed. Would you do an EUS?
I would still do it. I would still do it. I want to make it into the protocol because it's easily available as compared to MRI. We don't get dates that easily.
Okay, Dr. Saab, can you elaborate? See, listen once more. A tumor starting from 1.5 centimeters from anal verge, fixed, posteriorly located. Would you do a EUS? Will EUS help?
I'm saying this is all resource dependent. In our setting, for example, in Kupwara, we don't have an MR.
Mike.
Hello? So in our facility in Kupwara, we don't have an MR facility available, and definitely endorectal ultrasound would be a preferred choice.
I'm again repeating. Dr. Shabnam.
No, for this very case that you actually said was 7 centimeters in length.
No, yes, it was
Previous
going up
one,
to
there is
7
no
centimeters.
role of endoscopic ultrasound in this case because you don't expect a 7 centimeter length tumor to be just T1, T2.
Yes.
Right, and that is where the role of the endoscopic ultrasound comes in. It is just T1, T2. It doesn't have much of a role in the nodes. We are more worried about, in this case, about the nodal burden in this patient because that's going to change the whole scenario. And when you spoke about the MRI, I would not just stop at T3. I would want you to speak about T3, A, B, C, D, because that is the role of MRI. It's going to tell me whether it's a good prognostic disease or a bad prognostic disease. Is T, A, B. Then if it's upper rectal tumor, I will just do upper, probably last year I would have done upfront. Now we are in an era of TNT.
Dr. Saab, I was actually why I was focusing on posterior. The posterior placed rectal carcinomas, EUS is not helpful. EUS is not helpful because you don't have any organ posteriorly to see it. So anteriorly it is helpful, posteriorly not. Second, it's fixed tumor, and if it is extending view, you don't. It will be T1, T2. It's not going to change much. You presume it to be more than T2, T2. It's T3 or T4, that's MRI. The second comes T4, T3A, T3B, Dr. Shabnam pointed out. Can you help on that?
Yes, again, the T3 staging, like Dr. Shabnam said, it has 4 categorizations. Depending on the infiltration of the tumor into the mesorectal fat, T3A would be like 1 mm, 2B would be like 1 to 5 mm, then 5 to 15, and subsequently up to more than 50.
Because see, that has a good bearing on it. In fact, there are studies coming up which are characterized, as ma'am was saying, regarding prognosis. Even some in upper rectal cancers, the treatment changes. We don't go for neoadjuvant, we can go for upfront surgery also. Okay, now tumor markers, Iqbal sir.
Definitely it will prognosticate later on, it's going to help. It's going to give us some idea, and afterwards, if there's a sudden rise in the tumor marker, certainly that's going to tell you that something has happened which should not have happened.
Do we need to do anything else before, apart from some baseline investigation, do we need something else before planning this patient? Any other investigations? Dr. Shabnam? Anything else? Maybe not standardized, but would you like it?
CT chest is what we are probably missing out for the staging part
no,
of
CT
it.
we have done it, yes, we have done it. Anything else?
No, CE, we would do it, but it has to be a secretory tumor for that.
Yes.
Only 10 to 15% of the tumor is going to be secretory. So if it's not raised in the beginning, it's not really going to help in the later follow-ups. But if it is raised, then you might just follow it up. Or if all of a sudden you have some subclonal selections down that are coming up in colorectal cancers also, it might start secreting later on.
Yes.
And then otherwise nothing beyond that. We are in an era of liquid biopsies, but that again is costly affair and a little, not feasibility, availability, everything is an issue. But I think the future is near wherein your ctDNAs might help in that rather than the CAs.
Okay, sir wants to say something.
Do we have liquid biopsies here? Is it being done in the private sector, not in the government sector as of yet? I think probably in Karanagar they are doing it only in one place.
Only one place. So now we have moderated differential adenocarcinoma. Staging is clinically T3 and 2M0. Let us take it from here. Dr. Shabnam, what would you do? Lower rectal cancer, T3 and 2M0.
TNT, radiation with consolidation chemo, and then reassess after 8 to 10 weeks.
Okay, TNT. Dr. Reis?
So various options are there. One is neoadjuvant chemoradiation therapy, another is TNT. Now numerous trials have been there, some favoring TNT and some favoring neoadjuvant chemoradiation. And both are having their own advantages and disadvantages.
Dr. Shabnam, why TNT? I say I would like to take this patient for, say, neoadjuvant chemotherapy. Why TNT?
So we have trials like Rapido, we have OPERA and all that have looked into organ preservation. We are in an era where we want to preserve the organs, and it's 2 centimeters from the anal verge. So I would want to see, it was T3, so the intersphincteric space was also okay. I would want to give this patient a stoma-free life, if that is possible, and I have some distal margins going up, or at least able to do an intersphincteric resection. And in an era where we are having increasing evidence in favor of the wait and watch also, which is coming up, not a humongous amount of the data, but you never know how is it going to behave. And if you give systemic chemotherapy, they really respond well. And today we are talking about the complete pathological response, which is translating into the disease-free survival and overall survivals. And why would I not give the benefit to this patient?
I just want to talk about one thing. See, yes, sir.
We have till now in the last 2 years operated around 8 cases who got this TNT. They were declared disease free, and within a span of 3 to around 1 year we had recurrence, and exactly at that place. So we have to understand the biology of the Kashmiri gene. It's not the same as Western gene, it's not the same as Eastern gene. We have to see how do our patients behave. And because we are seeing these patients regularly, the footfall is too much, we have come to the conclusion that no, yes, give chemorad, downstage it, do whatever you have to do. Because at the end, what do we want? We want a patient who is alive, who is well, and who is disease free.
See, there are actually three parts in this. I would like to. So one thing is, in this locally advanced rectal CA, it is a bulky tumor because T3 and N2. We have 3 options. One is you go for a definitive CTRT or neoadjuvant CTRT and operate. One is this. Second is you go for a CTRT only, then wait and watch third is you go for TNT and wait and watch. So sir is saying that we would like, their protocol is there, neoadjuvant chemo and operate. The reason sir is giving that there is more chance of local recurrence as sir has seen because of some limited patients. Dr. Shabnam, you would like to say something?
Firstly, we don't call them recurrences because they are regrowths only and they are within the fibroblastic domain. So the secondly, if we look at the the evidences coming from across the world, which is Haber-Gamma was the largest series, they have 80% of the times, 80% of them if they even recur after 3 years of the follow-up, 15% of them if they recur, 80% of them are salvageable, right? So you're still able to salvage the patient as well as the sphincter. So I won't mind giving my patient with an informed decision 2 more years of stoma-free life and then operate when they have a regrowth if it is salvageable. And what was the second question?
Main was this only. I would like to add a point. Sir's concern was 8 patients had recurred.
And second, our genes are different is that we are part of this country only and we have studies from this country only that are going in favor of it. Yes. So I'm not quoting Western data.
So,
No, I would like to make an exception. No, our genetic makeup is different. It's after Banihal, the genetic makeup is different. I will not listen to that. We are having Dravidian genes or Aryan genes. No, we don't have
I would like
those.
to make a point. This gene thing will not come in. I'll just make a sentence. What was seen in a British trial, the latest 8-year data has been updated a few months back. They had seen that 50% of patients recur, as you have said, they recur, and then we have to do a salvage TME in them. But after salvage TME, the survival of those patients was equal to the patients in which we had done upfront TME, I mean after the neoadjuvant treatment. Yes, so it is actually the survival is same. So our survival is same. So we would not mind to give a patient 2 or 3 years a stoma-free survival after stoma-free period because it doesn't affect the survival as per the latest data jo hamare paas hai. One. Now,
Haber-Gamma regime, that a huge series of 197 cases and about 60% of them had complete pathological regression of the tumor.
That complete pathological response coming from 20% to 60% was only because they waited enough, because chemotherapy works in a different way and radiation therapy works in a different way. So radiation therapy works in the tissues 8 to 10 weeks later and 12 weeks. So what they did was that they did the surgeries in between 9 to 14 weeks. But we as surgeons say that there's a lot of fibrosis, so we take a cutoff of 8 to 10 weeks. But if you wait longer, you might get wonderful results. And that's the reason the trials that had radiation going first and then consolidation chemo, because they waited long, they got better results.
Yes, sir, that's what. Okay.
But sir, who decides that there is complete pathological response?
Actually, sir, would you like to take the question? Okay.
So there is basically, as of now, we see a lot of criticism for everything when it is introduced. That was the same case as laparoscopy, which has become a standard these days. We as a scientific body have to look into the evidences and then look into our own resources, look into our own patient population, and rather than cribbing that West has a different population, we have huge number of the data, 75,000 patients every year, which is beyond the registries actually. So let us create the data the way other people are doing, and then let's devise the kind of follow-up. The only issue with that is follow-up. People are saying follow-up gets very costly because you have to do endoscopy, rectal examination, MRI. Please talk to the population that is getting cancers, majority of them in 40s of age, and then for the whole life they're having that stoma bag to be changed every 3-4 days, and that costs them 700, 800, 900 rupees, and it's a lifelong process. So when we talk about cost effectiveness, we have to measure everything. We have to measure the issues that they had with that stoma that led to the loss from the work, that led to the sexual and the personal issues, that led to the loss of jobs. Everything else has to be put into picture, and then we have to see what is that, what it works for us, and whether we can do 6 monthly. So 3 monthly versus 6 monthly follow-ups we can do, or we can devise any other methods which are cheaper. And that's what we have to look at like a scientific body rather than,
Excellent, very good. But you're dealing with a subset of patients. What about a hospital whose turnover is only in the surgical branch 1,400 patients a day? Where are these patients? Because I am very straightforward. Okay? Science is one thing. I have to look at my resources. I have to look at my patient population. Then I have to look at what I am going to give them. They will not be able to see me for around 3 months, 6 months. It's so hectic going there. It's not possible. It's only those people who have a limited practice, who can see these patients 24 hours a day, not for those patients who are really poor and who cannot afford to come regularly for such follow-ups.
I would like to add, Dr. Shabna,
Just a quick comment. So TMS sees the highest number of the rectal dissections per year in any category, and if that trial is being done there, I think it's possible anywhere. And second thing, when we're talking about the wait and watch, we're not talking about those 1,400 patients that are seeing our OPD. We're talking about the low rectal cancers, which is like 5 to 7% of the total colorectal cancers that we are seeing, where we are preserving the sphincter. So I think the load is not really very much.
And I'd like to make a comment. Once, see, wait and watch policy after TNT is not a standard. Let's be clear, it's not standard. After TNT, if you have to opt for a wait and watch policy, there is a detailed discussion with the family and the attendants and the patients. Only when they agree to the regular meticulous follow-up is it advised. So
No. How many of yours
yes, that's what I want to say.
are mature enough to understand what you're telling them?
Sir, I want to come there. In SKIMS, I was in SKIMS, I think 2 years back. I left it 2 years back. At that time, TNT was coming up. We had not approached, इसको हमने पूरा भी adapt नहीं किया था. But definitely CTRT was still there. And all our patients who got definitely CTRT, we gave them a good counseling that if you want a stoma-free interval, these are the 3 things you have to do. If you are okay with it, we'll do it. If not, you go for surgery. And let me tell you, sir, 80% of them said, we will wait and watch. They said, wait and watch. But the thing is right, how many turn up for regular follow-ups? That's a concern, that I agree. But this option has to be given. Because it's a stoma-free time, you can give the option, it's their choice. They want to do it, they don't want to do it. But option should be given.
I would suggest that if the patient is from a place where he can regularly visit the hospital, is mature enough to take a decision based on how we have counseled them, then yes, this approach can be taken, provided he is able to come regularly for follow-up.
Yes, that's well taken.
One quick comment on that. So we are having cancer patients. For breast, the follow-up is 20 years. For the colorectal cancers, you declare them cured only after 10 years. Anyhow, if your patient after the rectal dissection is not coming for follow-up, then this patient will also not come. If that is coming, then I think this patient will have that apprehension of having the tumor inside and the comfort.
He's more worried about multiple investigations. Okay.
Yes, that is the only issue, and we have to sort that out.
Dr. Rees, which investigations in
One more
wait and
thing,
watch?
it's not pathological response, complete that's important. I think it's clinical response.
Yes. So what are the 3 tests would you like to
Because it's
keep?
difficult for a pathologist, even pathologist, to differentiate between dead cells and live cells.
So what are the tests which would like to conduct on follow-up, and how regular would the follow-up be for those patients who are on wait and watch category?
So first follow-up should be
No, I have a question for sir also. I have a question for sir. Yes.
first follow-up should be at 8 weeks after this
No, I mean to say a patient is TNT. We have said that he is a clinically complete response. Now, how regularly would you like to follow him, and with what?
every 3 monthly for the first 2 years.
Okay,
That's
with
important because
every
majority
3
of the recurrences they are within the first 2 years.
What do we do? What tests do we do?
One is CA levels, then clinical examination, then colonoscopy every 3 monthly, then MRI.
You mean a local visual examination? Endoscopy means that in this,
yeah,
because you don't have to take any biopsy. You mean a local feel with the finger
Yes, feel,
too,
yes.
and you mean an MRI finding.
MRI findings.
Dr. Saab, on MRI, how would you tell me after 3 months? I would say, Dr. Saab, it looks fibrosis. Can it be fibrosis or a disease?
A disease. Well, for that we have a biological marker for an MRI, which is a diffusion weighted imaging. A high B value scan would differentiate that, because the active. Hello. Because an active tumor, there would be definitely a diffusion restriction, and that's how we actually categorize that if the disease is still there or not.
In all the images you get once you are following up such patients?
No.
Or in some specific sequences?
Diffusion weighted imaging is the sequence of choice. T2 weighted and diffusion weighted imaging is what we would prefer in this. I believe diffusion weighted has an individual biomarker, is an individual biomarker sequence for this.
Okay, so after 3 years we have a local recurrence, we restage the patient, we go for APR, we go for surgery after 3 years. Our pathology colleague, I'm extremely sorry, there was, you were left behind, but now you get a specimen of APR, a TME, total mesorectal excision specimen. What are your criteria on grossly you would say that, okay, this looks like a complete TME? How do you tell us?
For rectal cancers, as we know that Yes, just like this. For rectal cancers, as we know that it's not covered by the peritoneum. For that, we have to inspect it properly, whether there are any where is the tumor and what is the gross level. When we see by the eyesight, what is the stage of the tumor? Has it crosses all the layers? Whether the it is intact or there is perforation? And that it becomes important for the staging later
You
on.
use Quinky criteria? You use Quinky?
Yes.
You use Quinky criteria for it?
Yes, but I don't
To see the
remember.
TME specimen. Okay. So this case is we had given him actually this patient had not taken TNT. It was I think 4 years back on the chemo RT. She is under observation since past surveillance for past 4 years, and she's disease free. But one thing is right, every 3 monthly she did not follow. That is right. She came 6 monthly, first year, 6 months, then she came yearly. But she's okay, she's doing well. So yes, let us go for the second case now. The second case is a 58-year-old female. She presented...
So I just forgot, you had mentioned in colonoscopy there was a synchronous lesion. Where was that?
No, I have not.
There was no synchronous.
No lesion. She's a 58-year-old female. She presented to us with abdominal pain, unintentional weight loss, change in bowel habits, clinical examination, mild abdominal tenderness, a palpable mass in right lower quadrant. Rectal examination, there were no masses detected. Colonoscopy showed a tumor in the ascending colon. So now, how do we go further? After colonoscopy, a tumor in the ascending colon, no synchronous lesion, biopsy, moderate differential adenocarcinoma. So, staging, Dr. Rees.
Staging, again, we'll start with tumor markers, CA levels for prognosis, and second is we'll go for CECT abdomen and test.
CECT abdomen in this case showed ascending colon mass with 3 metastatic lesions around 2 to 3 centimeters in right lobe of liver. Segment 5 and segment 6. Then next, what would you like to do?
We'll see the lesions, whether they're really metastatic lesions or some just simple cysts.
For that we do
or
what?
MRI liver.
MRI
to deal
liver.
in these lesions.
Sir, any role of PET scan in this scenario? CA levels are normal. MRI is showing 3 liver lesions, 3 metastatic lesions. Growth is in ascending colon. Do we need a PET scan in this case?
Do we have it available?
In
The first
SKIMS we
problem
had.
is...
In SKIMS we had.
Yes, we get the date exactly after around
Yes, couple
3
of
months.
Yes.
That's an issue.
But do we need a PET scan? That's what I want to say.
If we have it, okay. If we don't have it, you have to do whatever is necessary.
Dr. Shabnam, in this case, we need a PET scan?
If the CA levels are high, I would go for PET scan. That is one indication where you go for PET scan.
Okay.
Right? So that would be the indication. Now here I would want to see whether we have any other further lesions in the liver. So then a triple phase CT if it is not triple phase on MRI. And we have certain ultrasonologists who are actually doing much better job by doing endoscopy and telling us the lesions that have been documented as indeterminate, and we require correlational ultrasounds for these things. So PET CT if the CA is really very raised. Otherwise I don't see the PET scan giving me really added information if the CT chest has been also done properly, and that's it.
Yes. Now if same patient has multiple liver mets bilobar, would you go for PET scan?
Yes.
Why?
As of now, see,
Bilobar
it is,
mets, 8, 9 mets, unresectable.
Again, I think we have gone a little more aggressive these days. Unresectability is very variable
Subjective.
term. Yes, it's very subjective. So now the aggression is so much that even 10 lesions, centric lesions, bilobar lesions are being taken care of because we are not doing anatomical resections in them. So what we have to look into is if the local tumor, like the colonic tumor, is locally advanced, I would rather want to give this patient a benefit of neoadjuvant chemotherapy. So in that, I probably would want to do even a PET CT with this liver lesion, because then if there are any subtle things around, I might have missed them on the PET CT. That's what.
You want to give neoadjuvant? In this case, I just want to...
So last year I might not have wanted to. 3 months back we have had a study that has looked into the advantage, 10 to 15% of the advantage that locally advanced or synchronous upfront resectable cancers, colonic cancers, are having with the neoadjuvant. So that is where I would probably want, if it's not a bleeding tumor, not perforated, not obstructed.
Yes. So and then one more question. we give a neoadjuvant chemo in this patient, we reassess. After how much time on chemo do we reassess?
So for a liver lesion that is just 2 centimeter, I have to mark it because I might just miss it by a second or third.
And you mark
yes.
it by what?
Those are the markers, the clips that the radiologist, interventional radiologist puts in.
Yes. Say you have not marked it, because in SKIMS we did not mark it.
Then segmentectomy.
After 2 months, you have a disappearing liver met, and now we are in a soup. Segment 5,
if it's,
segment 6,
you have to
segment
remove the whole
7.
segment.
Yes. Dr. Saab, you want to say something on MRI about these liver lesions? When would you call them as unresectable?
I think unresectability is a clinical domain, and we would just go
What are high risk features? Dear, which structures which would you tell me?
I would say
don't go upfront.
I would
it's
say
unresectable.
the enhancement patterns, if there is a more solid component, the enhancement is more, and the size is more than maybe 4 centimeter, I guess.
Any critical structures it might be
If it
going
is
towards?
Any vascular
Yes,
or
yes,
that's true.
that's right. So but we need your, we had planned a liver resection.
I guess when we're talking about the PET scan, we were missing the important thing that the nodal staging is not completely possible by a CT alone, because subcentimetric nodes are mostly metastatic at times in cancers. So I think PET would be better.
See,
that's what I have seen that.
In colon cancer, PET, usually we do not use them for nodal metastasis. We take CT as a criteria, and you are brilliant radiologists like you are there to guide us, and we keep on bogging down your neck to just tell us whether this node is significant or not. One thing. Now, ma'am was saying neoadjuvant chemo, and then we'll reassess. Iqbal sir has something else to say?
No, operate. Because if you remove the primary, there is certainly an effect on the secondaries in the liver.
So, sir, what would your surgery be?
I would do extended right hemicolectomy.
That's it.
Laparoscopic with a D3 of at least I would have 15 to 20 nodes in my specimen.
Sir, D3 is based on a number of nodes or extent of dissection? Sir, please.
It's basically how much you dissect, up to what level you dissect, but the higher you go, the more towards the vessels the more number of nodes you harvest. And I want my pathologist friend to come in here. The problem lies there. We send them the specimen, but unfortunately they are so busy that they don't tell us that you have taken enough nodes. But I am very happy to announce that recently in one of our gastric cancers, they took out 47 nodes. It was a total gastrectomy, a total of 47 nodes, and around 11 of them were positive.
That's appreciable. That's good. Yes, Doctor, pathology. Yes.
Sir, so far as the nodes in the resected specimen are to be counted and concerned, we go for a minimum of 12 nodes in the colorectal surgeries, but we put more and more efforts to get them more. And there are the correlations, positive and negative. The positive correlation is if the tumor is, if the specimen is large in size, tumor size is large, there is not so advanced age, and it has a negative correlation with if the tumor size is small, specimen is small, perirectal fat, which they have provided us, the width is not so much, and newer techniques are being also used to get rid of the fat and to get the actual nodes. We put our effort there.
Iqbal sir, I have a question. You go for a right hemicolectomy, D3 in this case, and send the patient for chemo. What about the liver mets? They are resectable 3 mets.
If they are superficial, if we can resect them, we'll resect them. And all of this we'll do laparoscopically. So the patient will have an additional benefit that we will not be disturbing his internal milieu to that extent once we are exposing his intestines to atmosphere.
Dr. Shabnam wants to come in?
So there's a huge lot of controversy regarding the single stage and the double stage surgeries, and there is data that favors these 2-stage surgeries in terms of having shorter duration of your patient, shorter exposure to the anesthesia as well as blood loss. And when you're tired by the end of that surgery, the morbidity also increases. So I think the evidence is increasing. Although having said that, if it was an upfront resectable colon with upfront resectable metastasis, as I said, till last year the debates were that do it a single go. But now with the URTC new publication coming in and giving that added advantage of neoadjuvant, I think the only indication in a locally advanced colonic cancer with the metastasis would be going in if it is perforated. Because if it is bleeding, you still have, if you have in your armamentarium and interventional radiologist, which we have very commonly here, you can embolize. If you have radiation department, you can give a hemostatic radiation. If it is stenosed, if you don't have stents, please do a laparoscopic diversion, reduce the edema, send on 3rd or 4th day your patient for the neoadjuvant treatment, and then take them up, plan and take them up later on. There is no indication except for the perforation, because you don't have an option in there to go upfront for these surgeries if they're metastatic, because we have to understand it's a systemic disease. And there is no study that says that if we remove the primary in the colon, the metastasis is going to be, it's going to be deleterious, except for M1 trial that was for breast and that we did in TMH, and that too had a lot of subgroup divisions and analysis then. So I think we have to go by the evolving evidences, and we cannot state what we have been doing throughout.
Yes, this patient, sir wants to come in.
What is the problem in resecting? If you can resect it. And as to, because we are going to remove the primary tumor, you are going to remove the tumor bulk, you are going to remove the doubling time of the tumor. So still you are going to get a chance, your chemo rad is going to work better because you have a less tumor load. So that is an advantage. But unfortunately, we have just become so tuned to the papers that we are forgetting what the basic is.
Actually, sir, in this case with the resectable liver met, there was, Dr. Shabnam was right, there was a debate initially, and in fact, many were, even I was considering,
I think the audience has some questions.
Yes. Yes, sir.
Moderator is there, not here. Moderator is there. Sir, we can hear you without this.
Yes, sir.
Hello.
It was nice. And it was you enlightening for everybody. But the question is, what all trial I have done worldwide as a doctor and in the surgical department.
Hello, check. Hello. Hello, check. Hello, check.
What is the plan there? Honestly, dedicatedly, eight consultants from 8 specialties, they unite in one. Workup has been done. They make a plan. They give an opinion to the surgeon. We want a left colectomy and we want a sphincter sparing, or we don't want it. We're not total. We want like this. There's already a set plan. Then about this pre-op, neoadjuvant, post-op, chemotherapy, radiotherapy, radioplanning, radiographic planning, PETs and importance of PETs are other things. It is already planned. There's a plan. There is no confusion, agreement and disagreement. What this panel had, it was in good faith, but there was a discrepancy. Yes, I will tell to madam that definitely I have seen all the teachers worldwide. Nobody is so strong to remove more than 3 liver nodes. One of the cases I had done, and I took 1, and they banned me because we took 3 out of this. Anyway, it was nice, but the question is 2010, and there is an approach. One basic thing is that cancer is a systemic disease, a biological disease. We have still not been able to control the biological behavior of the cancer. Whatever we do, no doubt, in a good faith, we improve the curriculum. But the question is, there are set principles which I think discussion will going on, and we in our sector and our clinicians and our clinics and our departments and everywhere, there's a set plan of program which Dr. Iqbal Salim as a teacher does it.
This is
we have a tumor board both in skins as well as in SMHs.
Yes.
All patients of malignancy have to go through that tumor board. The plan is formulated there. It's not formulated by us. Okay, so everything, it has a radiologist, it has a pathologist, it has a radiotherapist, a medical oncologist, and then the surgeons come. Then only they guide us, no, this is the case, please take it up like that. So never on our own that we will take a decision.
This patient, I would like to say, we had subjected her to neoadjuvant chemotherapy. after that, we did.
It was right-sided colon, so if I had the provision, I would probably have done the KRAS, BRAF mutation as well.
Yes.
And because that will give her an added advantage to
Yes.
go for EGFR or VEGF, and the PCR is going to be really good.
Well taken, well taken. We operated this gentleman, this female. We did a right radical hemicolectomy after neoadjuvant chemotherapy. All the three metastatic lesions had regressed in size, but they were present. We got an intraoperative ultrasonography. We did metastatectomy of all the three lesions in this case, and patient is on 2-year follow-up. She's doing well. She's disease-free. Regarding sir, your one point, I have finished all the cases are done. A wonderful panel, a beautiful discussion, and a responsive audience. But sir, I wanted to point one thing. The consensus guidelines, actually all the institutions have their institutional protocols for these cases. Like sir is saying tumor board is there, tumor board is there. But the confusion is there. There's a confusion between East and West. There's a confusion between Europe and America. The confusions are, the debates will go on, the trials will continue till eternity. The latest evidence which we keep on getting, the treatment protocols will be changing just based upon the evidence. That is how it goes. But initial protocols are there. Like we had a definitive CTRT protocol for locally advanced lower rectal tumors in SKIMS 2-3 years back. Now our protocol has changed. We have shifted to TNT in SKIMS, I'm saying. And same is in PARAS also. Our protocol in PARAS is also same, TNT. That's our initial protocol. Maybe some may agree, may not agree. But the management changes as the evidence keeps on piling up. Thank you. Wonderful. Thank you.
Thank you, Dr. Naveed. Actually, I would like to say that Dr. Naveed, I had called him the 11th hour, and he agreed to moderate this session, and it was a wonderful session. So thank you. I would like Dr. Harbinder sir to felicitate the chairpersons first.
Sir,
So
Dr. Gulzar, respected Dr. Gulzar.
Yes.
Hello, sir. Sir, before the conclusion, I want to say a few lines
Yeah, sure.
because I have not been able,
Yeah,
I have
go
not
ahead.
been asked any question, and I
Okay.
will be saying something. Everybody is very serious to make it a bit lighter.
Okay.
The sir was saying about the medical ethics, so I will continue that with a nazm in Urdu. There are few lines they have touched my heart, and I would like to share with all of you. इस दुनिया में जो हमारा किरदार है एक मुख्तसर है, एक कलील मुद्दत के लिए उसी पे है कि इसके बाद हमने जाना है, चाहे हमारी नेग्लिजेंस पकड़ी जाए या ना पकड़ी जाए, मैल प्रैक्टिस पकड़ी जाए या ना पकड़ी जाए, आगे जाके जवाब कहीं न कहीं हमें देना है. तो कुछ लाइंस हैं जो मैं कहना चाहूँगा. हम सब का किरदार मुख्तसर था, किरदार मुख्तसर था, कहानी में हम भी थे, 2-4 दिन तो किस्से फ़ानी में हम भी थे. ये दुनिया राय बनाने वाले ज़रा रफ्तगां से पूछ, कुछ आइनों का ख्वाब जवानी में हम भी थे. फिर ज़िंदगी ने दफ़तन मतला बदल दिया, पहले पहल तो मिसरे सानी में हम भी थे. ये बात और है कि वो मशहूर हो गया, मजनू के साथ दश्त मकानी में हम भी थे. बस, थैंक यू.
So I would like Dr. Harbinder sir to facilitate our panelists. Professor Iqbal Salim sir.
No, I have received one. It's enough. I have to set the example.
Dr. Isa Mandar. Dr. Wasif Bashir. Dr. Javed Rasool. And Dr. Shabnam Bashir. Dr. Naveed, Shah Naveed, the speaker, the moderator for the session. How like it? Nathaban. And you can, yes, please. You can shift. So with this, we come to the last session of the day, and but we have a quiz at 4:30. I think Dr. Arshid is on to it. So for this session, it's the expert paper presentation. I would like to call upon the stage Dr. Babar Rashid Zargar, HOD GMC Doda. Is Babar sir here? Dr. Ravinder Kumar, Associate Professor GMC Kotwa. Dr. Zakir Hussain, HOD GMC, HOD Rajouri, GMC Rajouri, sorry. He's not here. I would like Dr. GM Sheikh sir to chair the session. Please, sir. If Dr. Akhtar sir can join them, please. So over to you, chairperson. Dr. Zafar sir, you are here also. All, I think our speakers are only here. Okay, I think they are enough, sir. Is it okay? Two chairperson.
So, good afternoon, greeting.
Can be a Makhdoumi sir join them. Please, sir. Sir. You join, sir.
Thank you.
So, good afternoon, everyone. Greetings from Government Medical College, Kathua. So, this is the last session of the day, session 6, and there is an expert paper presentation. So, first presenter is Dr. Akhtar Ahmed Ganai. Please. So, Dr. Akhtar Ahmed Ganai is Consultant Surgeon, JLNM Hospital, Srinagar, and he will present the paper on TAP for inguinal hernia.
Respected chairpersons, first of all, at the outset, I would like to thank Dr. Gulzar and team for giving me an opportunity to talk about inguinal hernia. Since in the morning, much has been talked about inguinal hernia. So I have made it little simpler for postgraduate students of the periphery. Transabdominal peripheral repair is a common surgical procedure nowadays in all the hospitals of the state. Around 75% of inguinal hernias constitute abdominal wall hernias. So the lifetime risk is around 27% in men. Why definition abdominal peritoneal repair is a laparoscopic repair procedure wherein the surgeon enters the preperitoneal cavity inside the peritoneum, enters the preperitoneal space and places the mesh over the hernia. The peritoneum is then sutured and tacked. So you should know when you are going for a laparoscopic inguinal hernia, you should know what are the indications. Symptomatic hernia should be taken. Recurrent inguinal hernia, if it is done previously by open anterior repair, or if
I will request silence in the hall,
or
please.
if you have a bilateral inguinal hernia, probably laparoscopic hernia is a better option. Okay. So there are few relative contraindications, but absolute indication, as has been said by Professor Ejaz Malik, coagulopathy, intra-abdominal sepsis, severe cardiopulmonary compromise, and there are patients where they have a low ASS score, they should be optimized before you take him for surgery. So what are the advantages of UP? So it is a better option for recurrent inguinal hernia. You have a chance to have a look on the contralateral side so that you don't miss any occult hernia. And in patients where you have a previous abdominal surgery, TAPP is a better option than TEP. So as you know, every surgery has a complications. Laparoscopic TAPP also has a recurrence. In contrast to TEPP, you may have one more contraindication, the complication, that is port side hernia, where we enter into the abdomen at around 10 mm port. So 10 mm port should always be closed with what is called as port closure needle. And you may have visceral injuries or what is called as gut injury more than in TEP. So how to prepare a patient? It is always required that a patient should be put on the operation table before he empties his bladder. Restrict pre and post-operative fluid intravenous administration so that his urinary bladder does not get distended very soon, which would affect your surgical procedure. And if you expect there are technical difficulties after prostate surgery or scrotal hernia or an extended operation time, you should always try to catheterize them. The patient with a unilateral inguinal hernia should be asked to give his consent to allow simultaneous repair if any contralateral occult hernia is found. So usually the patient should lie flat with the hands tucked towards the patient's body. Head should be tilted at 50 degrees, and the surgeon will stand on the towards the monitor front side on the shoulder opposite to the hernia side. The camera assistant will stay on the shoulder side on the side of hernia, and the screw will be on the surgeon side. So these are port placements. You can have a 10 mm trocar, usually supraumbilical, at least 2 centimeters above the umbilicus, and the two other lateral ports should be at a line which should correspond to the umbilicus at pararectal area. The intra-abdominal cavity is visualized with a telescope, and intra-abdominal findings are reported. Any intra-abdominal pathology, if there is, you can deal with it. If a symptomatic hernia sac is identified on the contralateral side, our protocol mandates its repair. But as I said, the consent should already be taken. While incising the first peritoneum, it should be anterior superior iliac supplies 2 centimeters above and medial to it. The anatomical markers you should identify. You should see the epigastric vessels. You should be able to see bladder. You should be able to see pubic symphysis. You should be able to see Cooper's ligament. You should be able to see middle part of the iliopubic tract. You should be able to see and feel iliac vessels. You can have corona mortis in some patients. You should be able to recognize them. You should be able to visualize suprapubic cord and wall difference so that you don't cause any iatrogenic injury. So this is a diagrammatic representation of where you start. This is 2 centimeters above and anterior to the iliac spine. You go to preperitoneal, enter into the space till you reach the what is called as retropubic space, that is called as ridgy space. Then the next, what are the things you have to identify here? The aim of the laparoscope is to identify the anatomical landmarkers, site and type of hernia. In this way, the Trundleberg tilt should be increased to 30 degree to 40 degree. There are two dangerous triangles. You should know about them, as has been already discussed in the morning. Vascular triangle is triangle of doom, and pain triangle, that is where there are neurovascular bundle. So you may have, as I said, corona mortis sometimes you should be able to recognize it. So this is a diagram representation again showing the triangle of doom, and which consists of external iliac vessels. The triangle of pain, why it is called as triangle of pain? Because it is not basically a triangle, but it is a diagrammatic representation where the nerves are running. If you put in a taper or suture engulfing the nerve, the patient will eat your head because he will have post-operative pain. So they kindly do not place any staple or suture in this triangle. And do not try to open the fascia to see the nerves. So this is a diagram representation. This is a direct sac side. This is external iliac vessel. These are inferior epigastric vessels. This is vasa deferens. This is suprametic vessels, and this is peritoneal reflection. And this is the what's called as triangle of doom. This is the deep inguinal rim. This is iliopubic tract, and this is the area where you have a triangle of pain. So sometimes you can have aberrant obturator vessel, which is called as corona mortis. There is a diameter representation. This is a vessel. This is a vessel. This is courtesy Dr. What's called Vijay Lankar. He was operating a patient, and I took a photograph. This is with his consent.
You will have to hurry up,
So,
please. Conclude.
This is a direct hernial sac. You have to what's called as reduce all the contents, go anterior to it. A large indirect sac may be ligated proximally and divided distally without the risk of a higher post-operative pain and recurrence rate, but with an increased post-operative seroma. When performing inguinal hernia repair in women, extra effort should be undertaken to reveal and treat occurred synchronous femoral hernias. So deploying an anchoring mesh, a large 15 into 12 mesh should be put in. If you have a less space, it should not be less than 15 into 10 centimeters. It should be either sutured or tagged at what's called Kupwara's ligament. So kindly make it sure that you close the peritoneum nicely so that there is no further addition of gut with the what's called as mesh. So you have to identify and dissect the pubic tubercle across the midlines. To summarize, the contralateral Kupwara ligament, reduce a direct hernia, dissect at least 2 centimeters between Kupwara's ligament and bladder, identify femoral orifice and rule out femoral hernia, dissect indirect sac and peritoneum sufficiently to paralyze cord structures, continue dissection till cord structure lie flat and psoas muscle is visualized, dissect laterally beyond anterior superior iliac spine, identify and reduce any cord lipomas, provide mesh coverage to cover whole myopectoral orifice. Mesh should not be less than 15 and 10 centimeters. Sometimes bigger one is needed. Ensure mechanical fixation at place above an imaginary line that is anticipatory investment to avoid injury to the nerves. Thank you very much.
Okay, very good presentation. I think we are short of time and.
Sorry, I did not see it. There is some problem. I did not see it. I don't know.
Okay, anyhow, please. Thank you so much. Next speaker is, thank you. The next speaker is Dr. Shabnam Bashir, Consultant Breast and Colorectal Surgeon, Ujala Super Specialty Hospital, Srinagar. She will speak on recent advances in breast cancer management. Dr. Bashir, please.
With due respect to all the speakers coming in the row, I will request them personally to restrict themselves within the time, because there are some guests who have to travel a long distance and there are some things others to do. The committee has to do, and I'll be thankful to everybody. Sorry for the interruption. That's all.
Assalamu alaikum. At the outset, I would like to thank the organizers for giving me this opportunity to be here. And I've been given this daunting task of talking about all the recent advances in breast cancer management that have happened in the last, say, a decade or so. It is more than impossible to sum it up in 7 minutes. I will run through it. When you feel you're done with it, you just ask me, I'll stop. Hanji. Can I have my slides, please?
Yes, you can start.
So the overview, I'll just give you a quick overview. 23 lakh cases are being diagnosed every year globally, and we are having 2.23 cases, 2.23 lakh being diagnosed every year in our country as well. This is the #1 cancer in women and #1 cancer killer in the reproductive age group. And the lifetime risk that we are dealing with is 1 in every 28 women in our country also. Has this risk, and unfortunately, 60% of the women are presenting in advanced stage, stage 3, stage 4. And when I talk about 2.23 lakh every year here, it is just 1/3 of the actual number. That is what the cancer registries are saying. And we are having more of triple negative breast cancers and young age breast cancer. So what have we achieved in the last 10 or 20 years? We have moved towards, a lot of recent advances are there which have caused better survivals, lesser side effects, and what we call customized or tailor making of these cancer surgeries. So no longer you can call an ERPR positive stage 1 equivalent to an ERPR negative or triple negative or HER2 positive stage 1. So what are the advances in the imaging technology? In addition to the basic minimum of ultrasound less than 40 years of age and or more than 40 years of age and X-ray mammo, we are also having other advances. These are the minimum basic. Please get these two things done in your patients, because we are struggling in our practice having lumpectomies done without mammos, and then there is no other way but an MRI to see what has been happening over there. So MRI, contrast enhanced MRI using gadolinium is also very good, but do not misuse it or overuse it, because they are a very limited indication of MRI in the breast. A very high-risk patient, high-risk family, multicentric tuber, lobular carcinoma in situ, or any implant in place or post-lumpectomy. We are having 3D mammos also, which is called tumor mammosynthesis. Its predictive positive and negative value have been seen to be better than MRIs. I think one has been placed in SMH's Shireen Bagh. So, I mean, that's a very good facility that you can use. AI-based imaging. Now, we are looking into the role of AI. A huge amount of the data is being put into the machines, and then we are trying to see how AI can help us if we are having lesser number of the radiologists, if we are having a lot of these patients that we have to screen through. So they will actually see those flagging signs and tell you whether you actually need to biopsy this patient or you don't need to biopsy this patient. So they can help in quick turnover, and then they can reduce the burden on our pathologists and radiologists. So early detection, what is it going to help us in? If it is stage 1 cancer in breast cancers, we have a survival up to 99 to 100% in stage 1, and it drops down to 31% if it is stage 4. So that's the importance. So 3D recon and imprinting is very helpful if you are practicing an implant-based surgery, and intraop ultrasound if it was an impalpable tumor. So personalized treatment, I would rather fold my hands and request you all for any BIRADS 3 and beyond, never ever ask for an FNAC in the breast, because you're not reaching any conclusion. You're wasting their time, their money, your time, your money. I mean your expertise. So you have to have this minimum basic information. In today's era, when AGCC is talking about the 3 types of the additions in your own staging. One is TNM, then second is the pathological, third is the prognostic. In prognostic, you have to know the ERPR staging of the patient. You have to know the key 67 of this patient. You have to know what is happening to the HER2 status, because then only you'll be able to see and plan your patient. For current recommendation is any tumor beyond 1.5 to 2 centimeters. If it is triple negative or HER2 positive or triple positive, you will have to give neoadjuvant chemotherapy with targeted therapy to these patients to get a good pathological complete response, which can translate into disease-free survival, better disease-free survival and overall survival. Role of genomics is also coming up. We have genetic lab in University of Kashmir. We have IUST working on genetics here. We have our SKIMS is having a genetic lab. So minimum basic of BRCA gene testing has to be done. So it's the breast cancer gene. So BRCA1, BRCA2, because if they are positive, then you have to counsel them about multiple things. It's not always about offering them prophylactic mastectomies, but they have to be on close surveillance. They have to decide about the removal of their ovary, because by the age of 60, 70, 100% of them are going to have ovarian cancers. So you have to counsel them for the risk reduction oophorectomy. So that's very important. Advances in surgery, we have moved from 70% of the mastectomies to breast conservation surgeries, and from breast conservation surgeries we had this fear that bigger tumors or 2-quadrant tumors, then you have to offer mastectomy. But now we are having oncoplastic breast surgery. So what you do is that if you remove 20% of the volume, you just displace it, and whether you're doing Benally, round block, you're doing Grissotti, mattress rotations, you can just replace it. If it is more than 20%, you can displace it. If it is more than 20%, you can replace it using your LD flap, mini LD flap, or the intercostal flap-based reconstructions, which the breast surgeons are themselves doing, because we don't have the armamentarium of these plastic surgeons available all the time. It's very easy, doable, just one simple course, and everybody can learn that. Now, the role of robotics and endoscopy is playing in a huge role because we are doing more and more of nipple-sparing mastectomies, then skin-sparing mastectomies in patients who are BRCA positive because they will go for prophylactic sometimes, or patients who have extensive DCIS where you want to remove the breast but you want to spare the skin to give a natural look. So endoscopy is coming up a huge way. Sentinel lymph node biopsy, I had this privilege of doing the first ICG-based sentinel lymph node biopsy here. So what you do is basically we are moving from an era of complete nodal dissection, axillary nodal clearance, to an era where we are doing some sentinel lymph node dissections or low axillary surgeries. So low axillary clearances, if you're not having frozen section with you, what you do is, if there is clinical node negative, your examination is negative, your ultrasound is negative, then beneath the second intercostobrachial nerve, you just remove that part of the fibrofatty and the lymph nodal tissue and send it for analysis. Now, when you're doing SLNB, the blue dye alone will not give you a good yield. There are studies that show 97% of the sensitivity if you're using blue dye plus radioisotope. But the problem with the radioisotope is it has to have clearance of the nuclear medicine division, so it can be used very restrictedly. ICG is coming up in a very big way in these, and it has multiple uses. So if an institution that can afford can have an ICG, it is good for plastic surgeons, for your general surgeons, for your vascular surgeons, for your vascular flaps. You can use that and have the hot spots and remove them. Axillary reverse mapping. Now there will be, it is in post NACT era, and we are still not leaving the lymph nodes in patients who have converted from N1 to N0 in our setups yet. So if you're still having to do an axillary nodal dissection, what we do is a reverse axillary mapping. We inject this dye in the webs of these hands, and then we trace the dye up, and if the node is lighting up in the axilla, that means it is draining the arm. You don't have to remove it. The controversy was that you might leave behind the nodes that are draining the breast as well. So we give blue dye in the breast, and we give this ICG in the arm. So a node that is having both blue dye as well as ICG means it is an overlapping node. You remove that, rest of the hot nodes you can leave. So you're reducing the amount of the lymphedema in these patients. ERAS protocols are being followed. You don't have to put in any drains in the breast conservation surgery. You don't have to put in drains if you're doing just a sentinel lymph node dissection. Breast reconstruction, we are having whole breast reconstructions in the form of DIFs, trams, and then implant reconstructions. Implant is very costly, so not being practiced in this part of the globe. We have pre-pectoral and the subpectoral. Pre-pectoral is preferred these days. The changes in the new adjuvant chemotherapy are that we are now having more of targeted therapies. Should I wind up? Okay. So I don't think we'll be able to complete. Targeted therapies, HER2 positive, we have multiple agents. Then PARP inhibitors for the triple negative is a very good option if your patient can afford, because you don't have anything to offer to the triple negatives except for this. So why new adjuvant chemotherapy? Because complete pathological response is translating into a better survival in these patients, and we are looking into groups of the patients where we can omit radiation therapy, we can omit hormone therapy, we can omit chemotherapy, but we have to have a detailed analysis of that. In terms of the radiation therapy, we have multiple things, IMRT, IGRTs, IORT. IORT, if an institution can afford, is an amazing thing for a resource-limited region, because then your patient doesn't have to travel for 25 days for that radiation. One single dose of intraoperative radiation works for them. Liquid biopsies, they're still in the experimental stage, but yes, have a very big role to play eventually. And then risk scoring. In your strong ERPR positive patients, you can have a risk scoring. CAN assistance available, it is cheap, it is validated on our own patients. So you'll have to take a call whether to even give them chemotherapy after the surgery or not. It is doable. Survivorship, lymphedema has to be taken care of, their health has to be taken care of, their psychological issues have to be taken care of, and future is promising. Thank you very much.
Thank you, Dr. Shabnam. Nice presentation.
I'm sorry, I had to run through it.
Any questions from the audience?
No questions will be.
Okay.
Thank you, Doctor, personally from me, because you have covered an extensive subject, and I know you love this subject to speak anywhere. Thank you. I can say Jazakallah khair. Thank you.
No, you continue.
The next speaker is Dr. Zafar Salim Khande, Associate Professor Surgery, GMC Srinagar. He will speak on interesting cases in pediatric surgery.
So Dr. Zafar, we are really proud and privileged to have you showing us interesting cases in pediatric surgery. Tell us, how can we as young surgeons make your life easy? do something wonderful. Thank you very much.
His life is or our life?
Good afternoon, everyone. I'm Dr. Zafar Salim, Associate Professor, Department of Surgery. Am I audible?
Less audible.
I would like to congratulate the entire administration.
Excuse me. I please request everyone to maintain silence. In the last lecture also, it was too much noisy.
I would like to congratulate the entire administration, all the doctors, all the paramedical staff, for making this sub-district hospital a big success and doing all these courses here. Indian Association of Pediatric Surgeons is a big association, and they're contemplating for next 5 years to have a pediatric surgeon in every district hospital. So that is, these associations are very powerful and they are working at the central government level. So these are some of the cases which I want to present without wasting much of your time. So we had a lot of ultrasound is happening right and left. So they pick up these testicular masses. So orchidectomy is a really devastating procedure for parents, as well as a long-term psychological effects on children. Even though we have testicular prosthesis available, but still, testicular tumors, they have their salient radiological features. So the treatment of choice will be an high orchidectomy. It needs hours and hours of counseling with these parents. See, child does not understand anything what is going to happen to him. So testicular sparing surgery is where we take out the tumor and the functioning testicular tissue is preserved. So preoperative workup is extensive, which includes tumor markers, which includes CT scan of chest, CT scan of abdomen, retroperitoneal nodal study extensively. And then we take these children for inguinal approaches. And the main aim for us is to have histopathological examination, what we call as frozen section biopsy, should be available in the hospital. So we have that available in the SMHs. So we have been doing these testicular sparing surgeries. These are the ultrasound findings. You must be able to appreciate a curved artery clamp. The plaget on the top has been applied here to decrease to make it ischemia time has to be minimized. An incision has been made, which is the protruding part on the parenchyma of the testes, and you can see this testicular tumor is enucleated quite easily. And immediately they are sent for frozen section biopsies, and in case we find a malignant teratoma, mature and immature does not warrant a orchidectomy. Because preoperatively we must have done tumor markers, which includes alpha-fetoprotein, beta-HCG. So we are discussing prepubertal children. So commonly they have teratomas. So quite nicely they do. And then we send these children, we do a testicular sparing surgery. Then the main important thing in the children is the follow-up. If they have to recur, or if there is any malignant potential which has been missed, the recurrence will be within 3 to 6 months. So we'll be following them every 3 months for remaining 2 years, which includes tumor markers and chest X. That is more than enough. We have about 3 to 4 children in SMHs. They are under our supervision. At Touchwood, there's no evidence of any retroperitoneal nodal involvement or any chest lesion anywhere, or even local recurrence. So this is a child. He was about 7 to 8-year-old child. Sleep was disturbed. disturbed. He's breathing through the mouth. Are we able to listen to his snoring? So this child came up to at the age of 6 years. Got his radiology done. You can appreciate this is a retropharyngeal mass which is almost obliterating his entire airway. How he's breathing, how he's eating, it is still an enigma. And on axial scans, it's almost growing across the midline, involving the almost entire neck. We took this child for surgery. The rule in surgery is the structures which you think are going to get injured, you sideline them, you identify them. And here the structures which could have got injured were trachea and esophagus. So trachea was already secured by an endotracheal tube and the esophagus by putting an NG tube. This tumor was completely excised. The child is doing well. This is video while sleeping. He's sleeping completely noisily and the parents were really, they have slept after 5 to 7 years. One more child. Dr. Afaq remembers this child very well. Comes to emergency, soft distension abdomen. The Ryle's tube has been put in the stomach and it's a bloody gastric aspirate. It's a good X-ray for postgraduate teaching. So whenever you look at the X-ray, abdomen, never miss the chest. So there's a continuation of the bowel going to the left side of the chest and there's an air fluid level. So as in post-MCH, I knew what's the diagnosis, but still for medical legal reasons, we got a CT done. I don't have the films. So I knew the approach. I took a left subcostal incision. The moment I took the left subcostal incision, I could see the transverse colon dilated, small bowel was dilated. And looking inside, I could see the colon going inside the foramen. This is foramen of Ogdalek on the left side. So never pull on a structure. Never pull anything structure which is, never pull on a blindly, never pull blindly. I did a thoracotomy. I could see a gangrenous bowel inside. Because if I would have pulled from below, I would have definitely got his mediastinum also into the abdomen. Would have lost the child. It was a gangrenous portion of the colon in the chest. And you can see the transverse colon proximal and you can see the almost hepatic flexure in the chest. Sorry, the splenic flexure area. We did the mobilization, resection through the chest, pushed the structure back in the abdomen, did anastomosis, child did well. He's a 12-year-old child. He's a 12-year-old child with a history of circumcision in infancy. With a history of circumcision in infancy, comes to casualty with retention of urine. Our wonderful residents tried to attempt catheterization, failed. They have been instructed, just one failed attempt, don't go further. They did an SPC on him. So next day, on examination we could find these, you can see a scar on the base of the shaft of the phallus here. There's one more scar here. It was not leaking urine. It was passing through the urethra, but this time he had gone to complete retention. We do our contrast studies ourselves. So it was an RGU done where I could appreciate a cutoff here. So once we repaired him, degloved him, dissected all the corpora all around. So with where the stricture was, it was a silk suture there. So this fellow had been circumcised in his infancy, and it was what is known as Ruppenzell syndrome. So it goes around Torquid syndrome. So this thing had been dissecting throughout his last 12 years. Finally, it has reached the urethra, and it has obliterated his urethra, and he has gone. Thank you very much.
Nice presentation.
Doctor, thank you very much. only one with the permission of the chair. I have got only one question. That pharyngeal lymphangioma. Did you consult ENT people?
They consulted me.
They consulted you. Now, did they find it out? Did they? You have to take it out. They will not take it out. But they found it out because nobody will actually go to an ENT man or they come to you.
They had consulted ENT, but nobody had asked for a CT.
Okay, nice. Thank you. आप किसका है? We have got the now speaker is a wonderful young man. He is the man who has been groomed by his father. He is Dr. Rathar. Dr. Rathar is not presenting. His son is presenting. And I request his son and I encourage him not to get panicky because your father is in the audience. I think as a family, I know him, I know his family, I know all of them. A good father has produced a good son. We wish you all the best and you give something worst, something the best. Don't invite the criticism. Thank you.
Thank you so much, sir, for that kind introduction. I'll surely try my best. Would you please help me with the presentations?
Yes, Papa.
Assalamu alaikum. I'm Dr. Sanan Rathar, and today I'll be speaking about evolution of surgery, the untold story and hidden facts. Now, contributions in the field of medicine have often been over-exaggerated when we talk about the West as compared to our Arabian and the Indian subcontinents. Singh et al. Reported that there has been a systematic bias against Indians when we talk about the scientific history as discussed by the West. There have also been some highlights, some reports by some other individuals as well, which state that the Western aspect of the history, scientific history, it is maybe incomplete and maybe dare I say, it's a bit distorted as well. We all know about Galen and Aristotle, and they have been described as fathers of anatomy. But do we know that Galen was very often wrong in his anatomical findings? He never dissected humans. All his research was talked upon, it was descriptive of, animals, ox, pigs, and even some monkeys as well. And I think it's our duty to know more about, what the individuals from our subcontinent have done. And that's what we'll be discussing today. So let's start. Sushruta wrote one of the ancient surgical texts, Sushruta Samhita, and described the principles of anatomy, pathology, and surgical management in great detail. He has been known as the father of plastic surgery, and many reconstructive procedures he talked about, even skin grafting. Now, he also attributed that malaria was actually caused by mosquitoes and talked about various blunt and sharp surgical instruments. Next, Abu Bakr al-Razi, one of the greatest pioneers of Islamic medicine, known in the West as Rhazes. He is considered as the father of pediatrics. He wrote a very influential book on measles and smallpox. His two very well-known books, one an encyclopedia on comprehensive textbook in medicine, and other Kitab al-Bansuri, a book on anatomy which described in great detail the internal organs, eyes, veins, arteries, nerves, and even intestines as well. And you will be surprised to know that the concept of clinical trials, it was started by Al-Razi himself. Cases and controls, as we know them today, it was started by him. Described spinal cord in great detail, cranial nerves, spinal nerves, both this motor and sensory functions of them. A nightmare of medical students, how can we forget? The circle of Willis, yes. He described that, talked about
two arches which give off two vessels, one of which goes into the skull and which forms a beautiful network, what we know, circle of Willis. Talked about neuropsychiatric conditions as well, melancholy, epilepsy, many panic disorders, seizures even. He was the first to use opium as an anesthetic, first tested on animals and then used on humans as well. Talked about arteries originating from the left side of the heart. And yes, he corrected Galen in saying that stomach does not have two layers, but three, circular, longitudinal and oblique. Next we have Abu al-Qasim al-Zahrawi, one of the greatest surgeons, known as the father of operative surgery. He was the one who first used catgut, that's even widely used even today. Did the first thyroidectomy, invented numerous surgical instruments. His contributions in pediatric surgery are very significant. He devised instruments to inspect the urethra and also to remove foreign bodies from ear, nose and throat. Contributions in gynecology as well. You can see the instruments over here. And he talked about abdominal pregnancy, a subtype of ectopic pregnancy, instruments of cesarean section, instruments of cataract surgery. And a very interesting point over here, he preceded the French military surgeon Ambroise Paré, who is claimed to be the first to utilize sutures by around 5 centuries. That's around 500 years. Talked about treatment of anal fistulas as well, and his method for setting and reducing a dislocated shoulder. It was centuries before Coker ever did. Next, removal of urinary bladder calculi. He devised these forceps, a crushing forceps which contributed to lithotripsy, and a Dürrer fragment forceps to remove impacted stones. And what's wonderful is he talked about head injuries as well and how to manage them, skull fractures, SDH, and even described a case of hydrocephalus. Had some work in orthopedics as well, talked about amputations, dislocations, dental surgeries. And an interesting point that he is the author of Kitab al-Tasrif, which was a medical textbook used in Europe for a very long time. Next we have Abu Rayyan al-Biruni, tremendous work in the field of pharmacology, talked about the knowledge. It's important to know the knowledge of the drugs, how they work inside the body, rather than just knowing the mere preparation. We have Ibn Zuhr, who talked about cancer of the colon, uterus, and
silence, please.
carcinoma. Also performed the first tracheostomy on goat. And an interesting point over here, that he insisted on a well-supervised and a structured training program for developing surgeons before we let them to work independently. And he helped build the lines that when a physician should stop his treatment of a surgical disease and hand over to the surgeons, which eventually led to the development of general surgery as a specialty of its own. And how can we forget Prince of Physicians, Ibn Sina? He wrote a very famous book, Al-Qanun fi At-Tib, the Canon of Medicine. And it was this book that was used as a major textbook up to 17th century in all the European medical universities, which is a great feat. You can see 5 volumes, general medicine, pharmaceuticals, special pathologies, systemic diseases, and even pharmacopoeia as well. He believed that the optic nerve decussates at the optic chiasm, which opposing Galen actually. And he talked about anatomy of eye in great detail and talked about various ophthalmologic conditions such as cataracts. He discussed that tuberculosis is actually contagious. And an interesting point I would say, he discussed psychiatric disorders, the so-called disorder of love, which he considered to be an obsessive disorder resembling severe depression. Next we have Al-Nafis. He talked about blood's pulmonary circulation way before England ever did. We talked about lots of men so far, so we can't forget Rufaida As-Salamia, who introduced nursing to the modern world 1200 years before Florence Nightingale ever did. She established a medical tent in Masjid al-Nabawi at the time of Prophet, peace be upon him, and treated one of the companions of the Prophet in the Battle of Khandak, who actually injured his brachial artery, a very serious injury. She learned from her father, who was a trained physician. And even today, in the RCS Ireland at the University of Bahrain awards one student the prestigious Rufaida Salamia Prize for delivering superb nursing care. Her influence beyond the battlefield was very well noted as well. And she promoted public health within the community and trained other women to do so as well. We have Hakim Maisari, who worked on various health problems from head and toe, toxicology, fever, hair loss, everything. We have again Alauddin Abu Al-Hassan, and who worked on pulmonary and coronary circulation. We have Mansoor Ibn Muhammad, who actually was the first person to author the first color illustrated atlas of human anatomy. And you can see the pictures over here. So to conclude, the advances and innovations in medical science and healthcare systems that were achieved during the early and the golden Islamic ages, it has significantly contributed to the development and the evolution of global medicine as we know them today, and the creation of many surgical procedures which are widely performed. And we should remember our roots from where we come from and contribute to it further. Thank you so much.
Thank you, Dr. Salam. Last but not the least, I have to tell you, as our young son, you have practiced properly, and thank you very much. It was with confidence. Only one word I have to tell you, that medicine overall has come up a long race. Let's presume everybody has contributed something or the other. We should not forget the pioneers since last 1,500 years who came in different parts of the world. Medical history, their contribution, simple observations, their recognitions, and their recording of the observations which made the basis of future medicine. It has come. I will give a small example that old Hakims were giving belladonna water to the people who had congestion. But after all, after near about since last 150 years, they came to know this. It is something which will concentrate. So the thing is, we all as doctors, we should all be thankful to our forefathers who have given us to what we are doing today. We are consuming their bread which they have earned for us. Thank you.
Nice presentation, like his father. Last presenter is Dr. Harvinder Singh Bali, Associate Professor, ESCOMS, Jammu. Will speak on closed encounters in laparoscopic cholecystectomy.
So, I am here with the last presentation of the day about the surgery. Everybody has done this. And I've seen Professor Sheikh after a long period. So it's almost, say, 20 years after I'm seeing this today. Who's that? So, dear Chairperson, shall I start, sir?
Yes, sir.
Start, please.
Please, I will take just 4, 5, 6 minutes. Please be patient with this thing. And this is the last thing.
The
Your
sweets,
presentation, they will awake.
sir, the sweets for the audience after a heavy meal.
Okay, that's true, sir. That's true. Okay, the laparoscopy is the most commonly performed surgery. Everybody here has done it, and then there are the students who are going to do it in future. This will be the first surgery they are going to do. So, and since 1890s, this technique has largely replaced the open technique. And even in developing countries like ours, we do...
Speak close to the mic.
Even in developing countries like ours, we do at least 4 to 5 lakh laparoscopic surgeries. These cholecystectomies are performed every year. As it's the most common performed minimal access surgery, the chances of vascular and biliary injury are there. So, we need to be well versed with the biliary and the vascular anatomy. If you see the variation in the arterial supply, if you see here the variation, in 90% of the cases, the cystic artery arises from the right hepatic artery. But at times you will see cystic artery arising from the right, or there can be two cystic arteries. One arising from the right and one directly from the trunk of this hepatic artery. Then it can be either from the right hepatic artery and one from the left. And sometimes that's a catastrophe when the hump lies anterior to the common hepatic duct. So this is the cystic duct, the common variation. You see the low insertion of the cystic duct. Then adherence, it's very difficult to differentiate between the common hepatic and the cystic duct. So the chances of injury are more. Then high junction, it is inserted high into the common hepatic duct. Then sometimes it may be inserting into the right hepatic duct, or sometimes low into the duodenum, into the CBD. So we as surgeons, we need to be very cautious about these things while doing these laparoscopic cholecystectomies. So owing to such a varied anatomy, incidence of injuries has also increased, especially when the procedures are done by the inexperienced surgeons and the surgeons not well versed with the variable anatomy. There is a wide range. You see 0.5 to 1.5% of incidence of BD are bile duct injuries in lap cholecystectomy as compared to 0.3 in open cholecystectomies. So this is, you see, this is the cystic artery giving two branches. This is one to the right and one to the left, going right up into the then this, you see, whole of the GB is inflamed, but you see but the cystic duct which we have clipped is not inflamed. So always remember this thing, whenever there's an empyema or there is inflammation in the gallbladder, it is always distal to the stone. The cystic duct beyond the stone, that is never inflamed. You do the surgery, the cystic will be beautifully defined cystic duct, which will be always easily clamped or sutured. Then this is the same clean cystic duct after doing this empyema surgery. This is squirted from the cystic artery which we see, and most of the time it gives just a sprays on your camera and the surgeon is in the soup. So this is how beautifully this cystic artery and this cystic duct has been cleared, and ultimately they are ligated. And again a squirter. This is the bile leak from the ruptured gallbladder. This is again a lump, GB lump, which has to be aspirated before proceeding further. These are numerous stones of the perforated gallbladder lying in a peritoneal cavity. And this is a cystic branch, cystic artery arising from this hump of hepatic artery. So here I present a case, Shivani Rena, 44-year-old female. This is the thing when we started this, the thesis was done in 2004 in our institute, where all the case, this laparoscopic cholecystectomy in acute cholecystitis was done. So Shivani, 44-year-old female, housewife, diabetic on oral hypoglycemic. She was admitted with acute cholecystitis with GB lump in a tertiary level hospital she had come to us, and the decision taken, and she was operated within 48 hours, and she was discharged after 2 days. So you can see this. Initially, we thought this as a, we were not able to get the cystic duct, and so we tried to pull the gallbladder, and this was the CBD which we are pulling from down under. So, but luckily we were able to get it, and with a lot of patience, this thing was, I have fast forwarded it, otherwise it took us around 1.5 hours of doing this. Though this is the posterior dissection, which is the most common, which we should start, should be done. So this is the CBD going up, and we are trying to get the cystic. And the best thing to do in such cases is the hydrodissection. It's the safest thing for this inflamed and this patient with empyema and acute cholecystitis. So again, once you dissect all these things, you will see the cystic duct can be easily clipped, and this can be divided. So see how dangerous it was having just CBD pulled off in this case. So this is the second case. Sukhdeep Singh is 34-year-old male, engineer by profession. He was also a diabetic on OHs. He was admitted in a tertiary care institute in Jammu as a case of acute cholecystitis. He was managed conservatively on antibiotics for 15 days, but there was no relief. He reported to our hospital, but the lump size kept on increasing despite conservative measures. So we planned to intervene, and laparoscopic cholecystectomy was done, and the patient was discharged after. The film will not be good. This is the initial days. This is of 2004-5, I think. So this is the momentum what you are seeing. In frame of momentum, we are not able to locate the gallbladder. This is the whole momentum. Gallbladder is not visible at all. So patient on antibiotics from 2 to 3 weeks, but no response. This has been fast forwarded. It took us 40 minutes to locate the gallbladder. Patience is the key. This has been fast forward, so you are seeing the moments are very fast. Otherwise, you have to be very, very patient. Very, very patient. We are trying to take this momentum, a thickened momentum from this gallbladder to get to the Caller's triangle, which was our aim. But so now, this is the black thing what you are seeing. It was a case of a gangrenous gallbladder, which was where the people were trying to manage conservatively, despite all these things. Not. We have it's all black. This is totally gangrenous, but luckily it was not perforated. There was no generalized peritonitis as such. So this you can appreciate them. This is gangrenous gallbladder with hemorrhagic patches over it. And again, once we aspirated the gallbladder, aspirated the bile, and then after we just localized the cystic duct, again cystic duct was clear, clipped it, clamped it, and the cholecystectomy was done, and patient was done and discharged after 48 hours. So the biliary and vascular anomalies are to be taken into consideration while doing laparoscopic surgery, this cholecystectomy. Any time is good time for doing. As one of our colleagues presented this thing some months back at GMC Jammu, that any time is good for doing laparoscopy. That's true in acute cholecystitis. Sorry. The hydrodissection is the safest one. Always start with the posterior dissection at Callard's. Cystic duct is never inflamed. Inflammation is always proximal to obstruction. Thank you.
Nice presentation. This marks the end of the.
Thank you.
today's session and scientific program.
I request personally Dr. Iqbal Salim to give a bird's eye view and comment about every speaker, which will convey that we are supporting you all. Please, Iqbal Saab.
In my speech, I talked about a very simple and basic thing, and I still stick to it. The safety of the patient is what we want. We want a safe patient, we want a safe surgery, and we want a safe surgeon. The idea of all these presentations that have been going on through the day is that we want to take the message right up to the peripheral areas of our UT, that we surgeons have to work together. We have to work as per the standard protocols that are there. Like, if I say that I would like to do a hepatic transplant, it's beyond me. So I should not think like that. I will think of doing a kidney transplant. They're not our cases. So there are people who are definitely for that. So as surgeons, I just have one thing. Can I have the silence here? If you're not interested, go out. As surgeons, I can only say one thing. Look at your surroundings. Then decide, is this patient in safe hands once I'm going to operate him here? Who is the person to whom I'll turn to help if it is required? And I'll make only one comment, that the person who will help you is your own self. When help is required, you might not be able, no senior might be around. But even if there's a junior, take help of that. 2 + 2 eyes make 4. No, they make more than that. They make a combined experience. So my only request is, please assess your surroundings, assess what you can do safely, only then take advanced cases. Thank you very much, and a big round of applause for Dr. Gulzar and the whole team of Kupwara Hospital. You have done a wonderful job. Can we have standing ovation for him? I think it was a right decision by the Jakasi executive that we must give Dr. Gulzar this chance, and a big round of applause for all of them. Hiccups are there, mistakes are there, they happen, but it's only once we attempt that we fail. We fail, we learn. We fail again, we learn, and then certainly success comes. Thank you, Dr. Gulzar. I hope your whole administration and your whole colleague, every person of you colleague, takes this personal thanks from me to their heart. Thank you very much.
Thank you, everyone. I am really glad to see all of you here. I have no words for this, that everyone has turned up. I was not expecting because of the weather. Really, I am very thankful. And it's not only me who is responsible for this. It is all the people behind me. It's not me. It's not Dr. Gulzar. It is the team Kupwara who really deserve this appreciation is really for them. And I am very thankful to them that they were on my back. Otherwise, it would have not been possible. So thank you all for coming. And I think Dr. Amir will make other announcements. And he has to do rest of the session. Yes, sir. So please be seated. We have something more for you. You have to bear us with another 30 minutes. You have done it, so bear us for another 30 minutes. Thank you.
Okay, thank you, Dr. Gulzar and team Kupwara for a wonderful show here. I guess we all should clap for them. They merit a clap. Please, huge claps for them. A really wonderfully well organized conference. इधर फेलिसिटेशन पहले इनको फेलिसिटेट कराओ ठीक है मगर पहले किसी
सिक्योरिटी का अनाउंसमेंट कर फिर फेलिसिटेशन स्टार्ट कर कि हमें सिक्योर हो इसके बाद होगा फेलिसिटेशन के बाद।
Silence, please. Silence, please.
I request Dr. Nazir Ahmed Wani, sir, Head of the Department of Surgery, GMC Anantnag, to please come on the stage. Nazir Ahmed Wani, sir. No? Sorry, sir, there is. Dr. Ejaz, sir, please. Sir, आप Dr. B.A. Makhdumi साहब, sir, please. Dr. Ravinder Kumar, sir, please. Dr. G.M. Sheikh, sir, please. Yeah, sure.
It is an honor for me to respect my teacher and guide who has been with me for a long time. And let me tell you, I will summarize him one word, that he is really the Hamilton Belly of surgery. Whenever I was a registrar on duty and I would call him, it would take him 5 minutes to reach from Bemina Hospital to casualty. On his own bike, he would never wait for the ambulance. So the dedication and sincerity and humbleness I have learned from him. Thank you very much.
Now the speakers, Dr. Akhtar Ahmed Ganai, sir. Dr. Shabnam Bashir. Dr. Shabnam Bashir. Dr. Zafar Salim Khande, sir. Professor Ejaz Ahmed Rathar, sir. आप प्लीज आए. Dr. Harbinder Singh Bali, sir. Dr. Priya Bhagat, PG Skims. Dr. Anil, DNB PG SDHK Kupwara. Dr. Shamsu Bari, Associate Professor, Skims Medical College. Dr. Shamsul Bari, sir. हो गया, sir. Dr. Junaid Ahmed Lankar. Dr. Abid Wani. They were the judges for the poster presentation. Thank you. Thank you, sir. Thank you so much. Now I request Dr. Akhtar Ganai to come on the stage to present mementos to the organizing committee. Dr. Mir Shafi, Medical Superintendent, SDHK Kupwara. Sir, Dr. Gulzar Ahmed Bhatt. Dr. Rais, Head of the Department, SDH Kupwara. Dr. Bilkis Ghani, Surgeon, SDH Kupwara.
Dr. Amir Iqbal, HOD Gynae, SDH Kupwara. Dr. Jahangir, Consultant Anesthesia, SDH Kupwara. Dr. Naveed, Consultant Anesthesia, SDH Kupwara.
Dr. Wasif Bashir, Radiologist, SDH Kupwara. Dr. Mir Iqbal. Dr. Mir Iqbal. Dr. Amir Bhatt. He is our backbone actually. He is our backbone actually. Dr. Ashik Bhatt. Dr. Anil. Dr. Sanjay. Dr. Ramakrishnan. Dr. Ejaz Ahmed Bhatt. Dr. Ejaz Ahmed Bhatt. Dr. Munir. Dr. Tayyab. Dr. Abhishek. Dr. Abhishek. Dr. Rahima. Dr. Rahima. Dr. Ejaz Ahmed Bhatt. Dr. Amir will take on his behalf. Dr. Alia, PG Obs Gynae. Dr. Manzoor. Dr. Manzoor. Dr. Rakesh.
आवाज भी नहीं देना MS का है इसका है
Dr. Sani Asnan.
Dr. Sani Asnan. Thank you, sir. Now I request our medical superintendent, Dr. Mir Shafi, please come on the stage. Mr. Ghulam Rasool Bhatt. Mr. Ghulam Rasool Bhatt. Mr. Amir Khan. Mr. Asif. Mr. Asif. Do not camera on, sir. Mr. Zamin. Mr. Tawfiq. Mr. Tahir Hassan. Thank you, sir. Thank you very much. सर एक है अभी सर अक्षु जल्दी Now I request Dr. Gulzar Ahmed Bhatt to come on the stage. Dr. Rakesh. Nahida Sajad. Nusrat Nazir. Rifat Akbar. Naida Farooq. Arifin.
These girls have worked really hard. I'm thankful to them.
Rubina. Rubina. Mr. Ashraf. Mr. Nazir Ahmed. Mr. Muhammad Ramzan. Mr. Muhammad Ramzan. Mr. Asif Ahmed. Asif Ahmed. Mr. Ghulam Hassan. and Mr. Munir Ahmed. Mr. Mubashir. Thank you, sir. Now I am going to announce the names of poster presentation winners. The first prize goes to Dr. Ikra Muzaffar. Dr. Ikra Muzaffar. Wonderful. And I will request Dr. Gulzar Ahmed Bhatt again to present the awards. Wonderful job. Second prize goes to Dr. Dalla Satya. Dr. Dalla Satya. And third prize goes to Dr. Ramakrishna. Now I am going to announce the winners of the quiz competition. The first prize is what? Okay, third prize. No, first prize. The first prize is won by Government Medical College, Srinagar. Wonderful, wonderful, wonderful. Congratulations. Second prize goes to Sher Kashmir Institute of Medical Sciences. And third prize again goes to Sher Kashmir Institute of Medical Sciences. Wonderful job, wonderful. Now, now I request you to bear with us for 15 more minutes. We have Kupwara Institute of Medical Science के कुछ students हैं जिन्होंने कोई skit prepare किया है. Please come to the stage.
So meanwhile, I am going to announce that Chakasi Executive Body meeting will be held in this hall only after this event, and that will conclude these proceedings. And for dinner, I would announce that it will be at 6:30. 6:30, because some people want to go back to Srinagar, so we just changed the time a bit. 6:30 at Vintage House. It is on the Chokibal Road, just 500 meters from this venue. So see you all there in the dinner, and these students, they are waiting since morning. So I think we should be here with them another 15 minutes. This is an event, they have created a theme on mental health awareness. So
thank you, Kupwara. We have a very wonderful time for the day. Now,
After this, we are having a very wonderful annual 11th Chakasikon conference. That will be inshallah at Pahalgam, and I am the host from GMC Anantnag. So we are looking forward for your presence at